and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we have let the speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may restrict in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. We received one submission for public comment, and I will now call on our speaker, Manager Cynthia Valadez.
Thank you all for being here today. I had a conversation with Manager Jones earlier, and I didn't realize he was going to be here virtually, but thank you, Manager Jones, for being here. One of the things that we had spoken about and are both in agreement with is to ask Dr. Bell whether or not it's possible to have or set aside a meeting for our Board of Managers to have a closed session or executive session discussion with our legal counsel and staff regarding the UT agreements. We have so many new members on this board that may not necessarily be familiar with the ins and outs of that, that we'd like to have a clarification meeting.
Yes. Okay. Yeah, is that with the budget?
No, this is the only reason that I'm bringing it up during budget and finance is because I thought that, and Manager Jones can correct me if I'm misunderstanding, that he'd had a conversation with our CEO and that they had talked about maybe putting it in or covering this during our budget and finance or maybe strategic planning, and I misunderstood. That's the reason I'm bringing it up today, since we hadn't had a strategic, we already had our strategic planning meeting. And since we were having a meeting today with regards to budget and finance, I wanted to go ahead and bring that up.
I appreciate that.
And one more thing, I appreciate staff for providing me a copy of the RFP, but with respect to outreach and information or community engagement regarding the equity plan, which I know is going to be one of the things that we're going to incorporate into our budget and finance strategies. And so one of the things that I'd asked for is at least the number of entities that applied for the phase 2 RFP, and how many of those may have been local, or how many had experience and success in addressing our demographic, or as demographics similar to ours in their areas, as an opportunity or for showing that they had that experience and that success in dealing with equity issues. So those are things that I'd still like to know, but I'm just bringing it up because I have some time left over. Meanwhile, aside from that, thank you. And I just, if Manager Jones can just give me a yes or no, did I cover that or not? I don't know if he can hear me.
Yeah, I heard you. You covered it pretty much so, but I'll raise it another time during our meeting this evening.
I appreciate that. Thank you very much.
All right, thank you.
We'll now proceed with the committee agenda. Thank you for your comments. First is to review the approved minutes of October 13th, 2021 meeting of the Budget and Finance Committee. Do I just say the next part? Oh, no. Okay. Go ahead.
I move that the committee approve the minutes of the October 13th, 2021 meeting of the Budget and Finance Committee.
All in favor, say
aye.
Aye. Any opposed? Any abstaining? Great. Let's move on to the next one. Receive and discuss a presentation of the proposed Central Health Fiscal Year 2023 budget and rate, budget and tax rate. Mike Beasling, John Morgan, Lisa Owens, Jeff Knoda will be presenting. Members, this item is a presentation only. There's no action on the budget or tax rate yet. If you have questions or specific aspects of the budget, Jeff and Lisa are available to answer written questions or to speak with managers individually. This will be the second time, not the final time, that we're seeing the budget for this cycle.
Thank you, Madam Chair. I'll provide some overarching remarks here to frame some of the discussion this evening. And as part of the discussion, we'll be real quickly providing very brief synopsis of some of the business cases that went into this. And so there's some staff that are present here in the room today that will help with that. And what I would ask John and Alan to do, if we can play musical chairs, and actually I'll need Elizabeth and Mackenzie, and I'm trying to think others. Some others have joined online, but if we could trade off chairs to allow others the opportunity to present their synopsis. This is the budget presentation, and it is built on board adopted objectives coming through the strategic planning committee, and based in large part on our health equity plan, but also continuation of prior year's work to bring it to completion. And so one year builds upon another, and it's built on data and insights, you know, from our patients that we're privileged to serve in the communities that we're privileged to serve. So the presentation starts with the numbers, so that you can see what very large scale what the sources and uses are. And then we'll move through the process to actually build the budget, and then the components that are the building blocks of the budget. And all of this aligned, again, with the board directives, you know, via the strategic planning committee and the board meetings that we've had. And then back to the start, to the numbers where we started with a much more expansive look into each of the line items within the budget. So you'll get a deeper dive into the budget as the presentation goes on. And that includes revenues and the dollar and allocations categories, as well as capital budget. All of this leading to the budget resolution. There's a draft budget resolution, which we can preview tonight, but it really needs substantive discussion later this month, as well as the final adoption in September of the budget and tax rate. And the budget resolution is important, as we've mentioned before. It's an official governing document of the Board of Managers, and it's our North Star. And we build everything around that. And as such, you can have directives and priorities set within this budget resolution, and you'll see a number of placeholders in there for a number of items that you'll see and hear about tonight, including the Dell Medical School. Despite some erroneous headlines that some people chose to print, this board, the official governing body for the healthcare district for Travis County, has a lot that it can do with all of its partnerships, including the med school. So with that, in keeping with our governance finance officer's designation of being open and transparent and very thorough in our budgeting processes, but most importantly, centering on the patients. And it's not just about the data, it's their voices, their insights, their stories that have helped bring us to this point today. And so we are pleased to present this budget. So right here on the screen in front of you, FY23 strategic priorities. You've seen these before. They've come through the strategic planning committee meeting, and really it's just for integrity and awareness. So we'll go to the next slide. This is the budget development overview. And so we start, as we mentioned, with the strategic priorities that are set by this body through the board meeting and committee meeting process. And we also have business cases that are lined up with the strategic objectives, anticipation of what those priorities are, and then we refine those, and ultimately that leads to the FY23 proposed budget. Now there are some issues that, excuse me, not some issues, there are some areas where it's a continuation of trend, and I can let Lisa or Jeff speak to this. So for example, for office supplies, we don't have a business case for office supplies. There's inflationary trends perhaps that are applied, same thing with insurance premiums. But suffice to say, through very prudent business practices and business cases and trend accounting, we come up with a proposed budget in line with the priorities as well as the fiscal forecast that you all have seen prior to this. So that's a quick overview of the budget development process. Next slide, please. So these are the business cases. Members, the business case process at Central Health is refined with each year. And why do we even bring this slide to you? Because there's a lot of technical and subject matter expertise that builds these cases. But one, to see you have awareness of it, and for transparency too. But it's also just so that you know what goes into what is necessary to not just maintain, but build a healthcare district that does what you have ultimately said, this is what we are going to go do. so that you can have that level of awareness. I will say that most of these cases have some level of staffing. We are growing staffing significantly more than what we have in prior fiscal years because of our direct provision of care. And if you think about this, Alan will, I'm sure, will be able to correct me on this, but if we're talking about hiring 5 providers, and that's just a hypothetical number, there are so many more additional individuals that we need to hire and bring on board to have culturally affirming care, but to support those provider teams so that they can practice at the top of their license and be highly effective in a highly effective healthcare system. Also with staffing, our recruiting efforts, there's a lot of work that we're doing on the HR front to build and rebuild some functions, and I'll report on, we'll report to you on that either later this month or in September. But suffice to say that recruiting, especially recruiting for culturally affirming care with diverse populations in the socially vulnerable communities that we serve, is front and center in terms of the staffing that, you know, whether it's clinical or non-clinical, as we're working through these business cases. So quickly, I'll recognize individuals to provide a quick synopsis and the why behind each business case. We can come back and talk about these, but they are voluminous. There's a lot of documentation that sits behind this, and I would say it would be a separate meeting and workshop where you need to carve out an entire day. Mm-hmm. That's the amount of, and that's just to answer your questions, but there's a lot of time and effort that went into this. So please understand, you know, why we're just hitting the high points this evening. I'll actually cover the first 2. Stephanie McDonald had put these together. One is a construction development. The next is a facilities management coordinator. It's the first 2 that are listed on the chart. As we are getting into more complex construction and or real estate, even if we're not constructing, it could be that we are renovating buildings and looking at other potential real estate opportunities to serve our patients. You need somebody that can function at a very high project manager level in construction and development projects, not to mention the upcoming work that is done around BRAC. Now, it might be consultant heavy, but still you need that in-house expertise to be able to function at that level. Second, the facilities management, construction and development. As you're building buildings, renovating buildings, bringing on more buildings, you have complex lease agreements. You need individuals on site, in-house that understand complex facilities management. And that's everything from mechanical systems to plumbing to other building systems that you need. Again, you can't just have all that contracted out because you're at risk. You need that in-house on-demand capacity for that, those facilities management functions. Let me pause briefly, and I know that she had some meetings this afternoon and some interviews of some candidates, but I wanted to see if Sherelle was able to join us. Okay, let me go ahead and move on to, since we have Mackenzie and Elizabeth at the table. Mackenzie, I'll recognize you if you'll jump down. So we're going to jump down this list here to risk management.
Hello, Board of Managers, and thank you for today's talk time. Although this rollout will be led by compliance, it will not solely be owned by compliance. Alrighty, I'll start over. Hello, Board of Managers, and thank you for today's talk time. Although this role will be led by compliance, this risk management function would not be solely owned by compliance. The risk management committee that will be assembled to look at risk here at Central Health will consist of leaders in our healthcare delivery department, finance, legal, and operations. And we'll start by looking at risk management in multiple buckets. But first, our larger buckets of knowing what the risk is as it pertains to Central Health as a whole, and then from there trickling down into the different buckets as it pertains to the different operational areas. But that's to come. Again, even though led by compliance will not be solely owned by compliance, it will be a very cohesive group of subject matter experts to, again, look at risk from the healthcare delivery standpoint, finance, legal, as well as our operational arms.
Thank you. So next I'll ask Elizabeth Moreau to discuss the Eastern Travis County Health and Wellness operations.
Hi, good afternoon. I'm going to go briefly over the Eastern Travis County staffing plan. Because of the new health and wellness centers that are coming online in 2023, we want to staff appropriately. That's going to be integral to the success of both clinical and non-clinical initiatives at the sites. We are proposing 5 new positions to work in this area. A program manager that can assist with existing programs and partnerships, handle events, volunteer management. They'll supervise some of the new administrative supervisors and other community outreach staff that are going to come on board. An administrative supervisor that's going to coordinate building issues on site meeting coordination. They'll supervise the community resource associates and administrative support staff. Also, we're proposing 2 community resource associates, 1 for Del Valley and 1 for Hornsby Bend. They'll be on site and will facilitate referrals and scheduling for community programs and resources such as MAP and the sliding fee scale for community care. We are also asking for a community outreach specialist. They will assist overall with the programs and activities, help when there are gaps in staffing, and assist with special projects as needed. The staff is going to need to be familiar with diverse communities. They're going to be very involved with the different enterprise partners that we have and different community partners. I think that's the best way in order for us to be able to bring in more patients and community members to be more involved with the clinic sites. It's been very successful at the Northeast site to have a community resource associate there, and Southeast, as many of you know, all the activities that are going on there and the patient involvement at those sites.
Thank you. Members, since we're moving down the list here, I'll go ahead and go to IT operational excellence, John Clark, and then I'll cover mission support, and then we'll circle back around to Sherelle on the HR.
Good evening, Board of Managers. Thank you for allowing me time to speak tonight. For Joint Tech's FY23 proposed business case, we're really looking to continue our efforts around IT operational excellence and our efforts in enabling the organization to meet and achieve the strategic priorities and objectives. It's important to consider that IT Joint Tech brings the technology foundation that everything else in the organization really relies on for the day-to-day operations, for the growth trajectory of the organization, and for all the net new objectives that are part of Central Health's vision and mission. As the organization continues to grow, so do the requirements for our network infrastructure, the number of our applications increases, the increased use of telephony, the increase in licenses of various systems, more security related concerns will present themselves, as well as demands on IT services such as field techs, and then from support such as our help desk. In addition, we continue to have more reliance as an organization on integration between various internal applications and systems, as well as the need to manage more data resources from both internal and partnering organizations. It's critical that as Central Health has and continues to grow, that the service of support functions like Joint Tech grow along with. This is to maintain our increased levels of service, and with the added efforts planned in the coming years, we are planning out the Joint Tech staffing for success, but more importantly, the success of major Central Health initiatives that need technology, like clinic construction projects, or where technology plays a major part, like in healthcare delivery. One of our ongoing efforts in Joint Tech is to continually to improve our tools and processes to create IT service efficiency. In addition to that, we have an obligation to the organization mission to enable efficiencies and effectiveness throughout every department. We are asking in this next fiscal year for support in building up the Joint Tech team in a number of resources and in structure to do these very things. First, to efficiently and effectively enable the organization with technology and IT services, to position Joint Tech for success in regards to growth that has already occurred in the enterprise and the growth planned for FY23, to prepare Joint Tech to achieve IT management, service, and support at higher levels as Central Health executes on its next 3 to 5 year plans. We're seeking an increase in Central Health's budget for Joint Tech of around $1.02 million, which represents 12 new FTEs, including a senior IT leadership position for technical operations, additional user support and field tech positions, application support positions, a developer / integration position or positions, additional cybersecurity positions, and a number of reclasses of titles. There's a couple of leadership position reclasses of network infrastructure and support positions, and then reclasses for some of our developers to reflect the work they're doing on integrations. These reclasses are to better align with the work of the organization and also to align the IT department and Joint Tech with industry norms. It's also to prepare us for continued evolution of Joint Tech as the organization evolves. Thank you, board.
Thank you, John. So next, what I'll do, actually, I'll go to Ivan Davila, who's at the table to talk about language access audit. And just a quick word on that. And then after Ivan, we'll go back to the HR and the mission support. Remember, some of the business cases, we put contingency funding in, and this is one that Ivan Davila is going to speak to. And basically what that means is there's some work that we need to do to make sure that we're ready. Because we want to make sure that we can responsibly spend those funds in a way that reflects, ultimately where we're headed in terms of fulfilling our mission. Ivan.
Thank you, Mike. So yes, this project seeks to hire a consultant to perform an assessment of Central Health's existing language access efforts and processes, identify potential gaps in accordance to national, culturally and linguistically appropriate services or class standards in healthcare, and develop a language access plan. This plan will include language access best practices to be embedded in Central Health's expansion plans, including direct practice of care. So we believe that a proactive, culturally and linguistically appropriate approach to healthcare delivery and outreach will help us connect with and care for those who speak languages other than English more effectively, and ensure a robust language access strategy throughout the entire continuum of healthcare, from navigation to clinical appointments. And this will be, the vendor will ultimately be guided by an internal advisory team that is made up of front-facing staff who will also be providing information to the vendor so that we can better maximize the vendor, as well as ensuring that we are also engaging with those most impacted throughout the entire process. Thank you.
Thank you. And next, we'll go to Sherelle Freeman, and she'll discuss 3 HR initiatives.
Hello. I'm discussing the Enterprise HR Benefits and Leave Specialist, the Enterprise HR Coordinator position, and the Human Resources Business Partner position. The first 2 being the Enterprise HR positions that would report directly into the CHRO. We included the Enterprise HR Benefits and Leave Specialist due to an increase in headcount due to the expansion for direct health services that we'll have on the Central Health side. And for the Enterprise HR Coordinator position, this was added as a restructuring. So we had a promotion within the organization, and then we included this to maintain the operations admin side of HR as well, just that dedicated FTE. And for the Human Resources Business Partner role, this was an addition. We added this to focus more solely on the strategic parts to maintain operations when the HR director is out and perhaps the CHRO. So this will serve as backup for those low level decisions that need to be made on a day-to-day basis.
Thank you. So lastly, members, I'll cover the mission support and resources. And basically, what this business case is designed to do is to make sure that all of the support functions that are necessary for everything that we do, that those are tended to. And so you've heard about HR, you've heard about technology, and there's many other facets to this, and facilities. Those things just don't self-coordinate. They also can get behind, and you can outrun those resources in a hurry. You all have heard us talk about this, but what the mission support and resources business case does is ensures that we have a program in place where those things are coordinated. There's a lot of thought put into how we build up resources, or in some cases, how we decommission them because they're no longer relevant to the course that we're headed, and we need to do something different. Now, there are some other things that are having to, and this one's a little bit more complicated because we're having to align it with some other work at hand. We've done a number of desk exercises starting at the first of the fiscal year, and even as recently as wrapping up in July of this year, to test ourselves and to understand what our working capacity and knowledge is. And so a lot of those test cases and desk exercises are being folded into this. Our senior HR advisor, Rayette Smith-Hearn, is assisting me with continuing to formulate this business case. But we've also got some organizational changes and alignments coming up as we start to think about how we look like a high-functioning advanced healthcare system that is much different from what we look like today. And so again, all of this has to be coordinated, but suffice to say there's enough knowledge at this point to put some financial placeholders in the budget to say we know we're going to have to coordinate mission support and resources, even if we call it by a different name, because you can't have a strong organization without that being aligned. So that concludes our business case run through. There's 3 on here: clinical services, infrastructure, clinical practice, and methadone maintenance therapy, which will be discussed in deeper dives further on in this presentation. But I want to thank everybody that has just either presented this evening or has just put a lot of time and effort into pulling these cases together. And it just, it's truly a lot of fun. At least I think it's a lot of fun, but I'll let staff speak for themselves. All right, thank you. John Morgan.
Managers, can you hear me okay? I think we got the microphone to work. At this point, we will transition the presentation a bit to sharing a few updates on the 6 clinical focus areas that were adopted by the board as part of the budget resolution for FY22. You can see here the 6 of the areas that we'll cover: specialty care, healthcare for the homeless, behavioral health, substance use disorders, and also including behavioral health into that component, clinical and patient education, transitions of care, and then our developing practice of medicine and medical executive board. Dr. Shalsha and I are going to spend a little bit of time on this slide, and we probably still won't do it justice. I mean, these are really just the highlights for everything that the organization is doing. The 2 of us have the pleasure and privilege of sitting up here and sharing the accomplishments of a very big effort by our team, our colleagues here in the room, our staff that aren't here in the room tonight. I've been here for 8 years now at Central Health, and I can say I don't think we've had a more significant amount of progress in service to our patients and the services that we provide than we have so far this year. So really pleased to share some of these updates with you. I should also certainly acknowledge our clinical partners in the community. You'll hear about many of those throughout this presentation, but we certainly couldn't do the work that we needed to do this year without those clinical partners throughout Travis County. So starting with specialty care. Specialty care has been a priority for the board and the organization as long as I've been here. And again, I think we've made some significant strides this year. We are certainly not done. Earlier this year, I think we've already shared, we started our first podiatric surgeries. This has been a multi-year effort with community care, with Ascension Seton, and here at Central Health in order to build a podiatry program that started off in the ambulatory setting. And now we have 2 full-time surgeons that are operating weekly, both in an ambulatory surgery center environment as well as in the hospital. That's a huge benefit to our patients and a service that has not been routinely available. There's a long list of expanded capacities across specialties. I can't name a single specialty where we don't still have work to do, but there is significant progress being made. These take the form of expanded clinics with our community care partners. These also take the form of new programs being developed, and also partnering and contracting with new provider groups in the community that have never been contracted to serve our patients. So we're excited to have those different expansions taking place. Outpatient dialysis services is one of our primary efforts for this year. That has been a planning effort for a couple of years, as you all are aware. And I'm happy to share that at the end of July, we were able to launch that program, and we have our first 10 patients receiving routine outpatient dialysis in the MAP program. And that is a new service and a life-changing service that we're thrilled to have operational and ramping up at this point. And again, have to thank our partners at Austin Kidney, our vascular team at Ascension Seton. We're continuing to build these programs, our Fresenius partners, and hopefully we'll have other partners down the road that we can share with you as well. We're not done here. Tubal ligations and sexual and reproductive health is also an area that we've continued to work on year over year. This year, we're happy to share that we were able to work with People's Community Clinic to start ambulatory surgery center-based tubal ligations for their patients. The contracting and credentialing and all that work is now complete, and People's will start those tubals at the end of this month, I believe on the 24th. So we're really excited to see that happening at some of the local HCA affiliated ambulatory surgery centers. We're also working towards additional agreements with UT Health Austin and the Dell Medical School. This is both for additional contracted services in their environment over at UT, as well as professional services, physician services from UTHA co-recruited physicians to work in our clinical environments that we'll talk a little bit more about for Rosewood, Zaragoza. In regards to healthcare for the homeless and the behavioral health components there, we're excited to have been able to extend our residential rooming for individuals experiencing homelessness through our partners at Fresh Start for the MAP Basic program. And another major advancement for us this year that's just in its early stages is the contracted medical respite services with a new entry. We've recently expanded to nine dedicated beds in that facility to help our patients who need a place to recuperate when they're leaving the hospital, or even a place to prep for a procedure that's a safe environment. We've been working closely with community care this year to expand our street mobile medicine services as well. Community care is in the process of recruiting a psychiatrist to support that service, and they have completed the process for ordering the dedicated mobile vehicles, 2 dedicated mobile vehicles that will also support those teams. Unfortunately, due to supply chain issues, it looks like those won't be available to us until later this calendar year or early next, but that is certainly in the works. Substance use disorder, behavioral health is another important focus area for us. We've really had several initiatives here, and I'll start with this expanded MAT program, the MAT or Suboxone program for opioid use disorders for our patients within the community care environment. This year, we've been able to really build out that program with community care so that it is fully operated by community care in their environment, and we're able to start building out this hub and spoke model for Suboxone treatment, so it's widely available for our patients. Again, the importance of expanded psychiatric access for those services is another key component. And right now, I think we're on track to provide about 2,000 visits annually for patients for opioid use disorder in the community care environment. Just as important is a new access point that we've worked earlier this year with Integral Care on. This would be located at Stonegate And I think we've talked about this a little bit at strategic planning, but this is for opioid use disorder patients that have co-occurring serious mental illness, so that they're able to be cared for by a psychiatric addictionologist in that integral care environment. So additional capacity and really trying to make sure that patients are being seen in the correct care environments. We also have one initiative that was not planned at the beginning of the year, but we try to stay flexible and take advantage of opportunities in the environment, and that's through methadone treatment. There is a serious need in the community, a growing need in the community, and we've tried to take advantage of the willingness of a couple of clinical partners here in Austin to do more in terms of services for our patients for methadone. So we've actually completed contracting with our first clinical provider and hope to start those services before the end of the month with Community Medical Services, and then hopefully have another provider online here in the near future as well. As Mike mentioned, this was one of our mid-year business cases, and because of the urgency of this care for our patients, we really didn't want to wait till October to get started. So we're taking an incremental approach for the fourth quarter of this year, and then in the budget for FY23, I believe we have $800,000 allocated for additional methadone treatment for our patients. And I will turn it over to Alan to speak to the rest of the slide.
All right, thank you. Good evening, Board of Managers. Can everybody hear me okay? All right, great. Excited to share some additional updates. Leslie Goodarzi joined us as our Manager of Education and Research a few months ago. She's a dietitian by training. She's working within specialty. Our CUC partners were generous enough to kind of offer their care environment, and really it helps us kind of wrap that care moving forward. Leslie is working on multiple educational opportunities. I'll speak specifically towards two disease processes and kind of those disease care continuums. The first one being related to renal disease, and the next one being related to cardiac disease. When we look at disease, we look at disease as it sits on a care continuum. I think here in the US, we do a horrible job caring for individuals, and people progress through that care continuum. And then we put a ton of resources into kind of end of life, care. As we mature as a system, obviously our goal should be education, screening, and putting more resources into the beginning of that care continuum. When looking at renal disease, we're doing both. So Leslie and her community health workers, in partnership with Dr. Tessa Novick, our UT partners, and our medical management team, are pre-screening individuals at the Mexican consulate and in other environments. And by pre-screening people, what we're doing is we're testing for any protein in the urine. If we find protein in the urine, basically that means that somebody may be progressing, down that care continuum, and many people are asymptomatic. And so that allows us to provide significant education and get people into the care that they need. At the same time, and I want to touch on what John spoke to, dialysis. When I first got to Texas about 6 years ago and met with the chief medical officers of the various hospitals, one of the questions I asked them was, what clinical problem can you not solve and is of critical need? And every one of them pointed to dialysis, that they hadn't been able to move that initiative. If you think about prior to what has been able to be achieved and access to patients who need to be dialyzed within the past few months, what happens is people really progress and get sicker and sicker and sicker. And then what we call is compassionate dialysis, which is really a misnomer. It means basically we have to administer life-saving dialysis in order for people just to be able to function. Now what we've been able to establish is vascular access for people, again, through partnerships for long-term access and predictable seats in dialysis clinics. So now people feel better. They can maintain jobs, quality of life, and longitudinal aspects to life are actually improved. And we're providing education on that end as well. So really, really significant gains. For cardiac disease, Dr. Shanti Nulu is our newest medical executive board member. She's a cardiologist extraordinaire and is helping. We have a heart failure program and have been providing education around that program as we progress and mature. So we want to provide more progressive preventative screening and in-home monitoring. And so we're building that program as we speak. Leslie and other team members are also working with partner organizations to sign affiliation agreements. And so as we build our clinical system, we're building a pipeline for training so that we can have, whether it's Austin Community College or other partners, we create access for individuals to train in our environment, ensure that they're culturally appropriate so that our culturally affirming care can improve. And then we can handpick the people who are not only mission aligned, but also clinically at the top of their game. In addition, we're looking at opportunities within our communities where scholarships may be appropriate. There are deficiencies in techs, in MAs, in MACs. If we can actually provide scholarships to individuals who live within our communities and help them attain the education that many of them would be interested in, we then create opportunities in an area where there is deficiency to reinforce and provide those individuals into our workforce. Again, reinforcing that cultural affirming care and just individuals that we critically need. Dr. Jewel Mullen and Dr. Hamali Patel, who sit within our medical executive board, also are diversity, equity, and inclusion experts. And so they are preparing education that when our care teams start, they will receive that education as well. As related to transitions of care, you can see on the slide that within our MAP basic population, we have been able to expand a significant areas of care, from pharmacy to hospice to palliative, home health, orthotics, prosthetics, physical therapy, and physical therapy. And so, this is significant. Anywhere where we can fill a gap or build a bridge, obviously our patients are less likely to advance in their care and to get better. Hamali Patel joined us a few months ago. She's our hospitalist, our transitions of care director. She's been working with partners, and in the next few months, we will put care team members both in the hospitals and within skilled nursing facilities. The fact that we've got respite stood up with 9 beds and we're working on expanding that means that as we put team members in these disparate care environments, especially because the systems don't talk to each other, we can start doing more hand-holding and transitioning our patients from one care environment to the next care environment so that they don't fall through care cracks. In addition, we're looking at what care would be appropriate in the home. And so if we can actually work and transition patients from the hospital to skilled nursing, to respite, and into home, prepping those patients or wrapping those patients so that they do well in their home and prepping them before they go back to our primary care partners, we stand a much greater chance of succeeding. Time flies. I remember sitting in front of you all. We remember sitting in front of you all last year when we were asking for finances to move forward to really staff our medical exec board and start the build of our infrastructure. We now have medical executive board members and directors who are diverse in ethnicity and culture and are really impressive individuals. The majority of these individuals received their clinical education in the best institutions in the US, whether we're talking Harvard, Yale, Johns Hopkins. It's incredibly impressive. More than half of them have a master's in public health. And the reason that that's important is it's not only what we establish that's important, but how we do it. And if people are thinking about systems and how to connect patients to not only the direct clinical environment, but to the social system and infrastructure that is so critical, that's just as important. And the most important aspect of this is they're all mission aligned. So when you speak to anybody within the healthcare delivery arm, our teams are positive, they're charismatic, they're energetic, and they're rapidly moving forward. I had once described Audrey Kwong, who did her undergrad studies at MIT, as having an MIT brain and a Disney heart. And I think if we had to characterize our MEB, they all have MIT brains and Disney hearts. And so we're at a really good point to really start building. We are also recruiting for a substance use disorder. I think, John spoke to the fact that we need to be able to adapt. And when we've got an epidemic within our environment, we need expertise. We need expertise to serve, to expand the care, and to also function as a convener, to bring organizations together so that we can move in the right direction. Next slide, please. Mike spoke to some of our strategic imperatives. For access and capacity, it's not only the clinics that we need to build, but it's the methodology that we need to change. So whether it's in-home monitoring or whether it's remote care by way of telehealth, we will be moving those initiatives. Care coordination, a really big initiative for us is our EPIC, our electronic health record system, and rolling that out. It's also medical management, transitions of care, and linking all of the parties. So I spoke to some of what we've been working on, and we are excited to bring that information to you in the future. We're also excited to have some of our medical directors sit and bring that information to you in the future so that you're not always having to hear from us. So up and coming, member enrollment and engagement. Obviously, the methodology by which we can enroll people is significant, again, so they don't have to leave their homes. And by holding our patients' hands from one environment to the next, we're much more likely to engage them and not lose them to care. So what we build will also increase engagement. As far as our systems of care infrastructure, that comes from the contractual relationships we contract, and the infrastructure that we build. Next slide, please. All right, there are opportunities everywhere. We will be touching on both significant and moderate gaps in care over this next year. If we have a significant gap in care, it means that we are meeting less than 50% of the community need. If we have a moderate gap in care, it means that we're meeting about 7%. But if we have a significant need, it's 50% or less. If we have a moderate gap, it's 70% or less. And so there are initiatives that obviously we're going to spend more time on, such as RZ, and John's going to speak to RZ in just a second. It's a significant gap, but we will touch every one of these opportunities in the next year. And hopefully when we sit in front of you a year from now and have this conversation, we can look back and we can see significant movement. Next slide, please. Provider shortages across the board. One of the positions that we have recruited and onboarded this year is a provider recruitment, onboarding, and wellness manager. Right from the very start, before we even start, and we are practicing medicine, obviously with podiatry, but before we start our own clinical infrastructure, we need to ensure that when a person drops a CV, or when we reach out to any individuals in our environment, we never let go of them. Right? At the same time, we need to be in tune with what those individuals are giving us as related to feedback and ensure that our efficiencies are where they should be so that we don't lose individuals to our own infrastructure. I can tell you that one of the first conference, so Dr. Nulu onboarded last week, and in my one-on-one with her last week, she said, Alan, I've never had a conversation about wellness on my very first visit. And her husband is an invasive cardiologist or an interventional cardiologist. She went home and she said, when have you ever had a conversation about wellness? When you have within any of your work environments, and both of them agreed it had never happened. So the fact that we're able right at the very beginning to start that build is really significant. In a time when there's provider shortages and just the economics within Austin are going to make it very tough for us to recruit people, we have to be creative and we have to do things well. Next slide, please. I'll turn it over.
Thank you, sir. So this is another slide that many of you have seen in prior discussions in our strategic planning and board meetings over the past few months. These are the immediate service areas that are really listed chronologically as we're continuing to build out additional layers of complexity in our direct practice. But these are all immediate, and these are things that are well underway. Alan spoke in some detail about transitions of care. This is where we are placing our providers and care teams in the hospitals and the skilled nursing environments and actively assisting with those transitions, those discharges from hospital facilities, whether it's into a post-acute setting or back into primary care. So we hope to continue to build that out going into FY23. Case management and home visits. You all made a significant investment in our case management team going into FY22. What this part is about is adding the ability to have those individuals, the nurses, social workers, community health workers, really work at the top of their license and capabilities so that we're not, just navigating and care coordinating, but those nurses and medical assistants and social workers can help folks on a clinical basis as well. I should note that requires and is our first implementation of our EHR EPIC, our electronic health record system, that's scheduled for October 1 of this year. So we hope to get these up and running very quickly. Specialty care, we're going to speak to in a lot more detail on a few slides, so I will move past that, other than to say this is really our main effort for FY23. It's kind of the culmination of everything else that we've been talking about, clinical infrastructure, our EHR implementation, the actual facilities and equipment and staffing all have to come together in order to make that successful for a go live towards the end of the fiscal year. And finally, medical respite. We spoke to this. I think Alan and I both spoke to this. What we're really doing is building out a continuum here, where today we have skilled nursing facilities that we contract with, and we have non-clinical shelter type and residential rooming or boarding home environments. What we're missing is everything in between. So what we're going to work towards is incrementally building out those clinical components to be able to provide better and better supports for our enrollees who are experiencing homelessness and need a safe environment. Next slide, please. So this is a slide that is very similar to one that you've seen in prior budget years, this and the next slide. And what this shows is one just measure of our progress in terms of primary care access. This slide speaks to encounters or primary care visits across our system. The subsequent slide shows our patients served. And you can get a sense here of our historical growth in terms of primary care patient visits, as well as a projection that shows a confidence interval based on our historical trend. We still, as you all saw on the slide that Alan spoke to, have gaps in every area. The primary care is one of those moderate gaps areas, and we need to continue working with our FQHC partners to continue building primary care access going into FY23. You go to the next slide, please. And again, here's unique patients served and the growth over recent years and projected growth out into the next 3 or 4 years. One thing I would point out that you really can't get to when these are on separate slides is our rate for increasing primary care visits is higher than our rate for increasing patients, which shows that we're also adding capacity for our existing patients as we're bringing additional people into the system. So another important component for us to keep in mind. Next slide, please. So we've had quite a bit of discussion on Rosewood Zaragoza. The team is very excited about this, and I can't thank Mike and all of our colleagues here enough for, we've really had a robust process of bringing all of our functional areas of Central Health together, a lot of coordination and discussion to make sure we're all lined up and we're going to bring the functions and capabilities that are necessary for this to be successful. The board earlier this year approved our initial work around design. We are completing our schematic design portion of the process now, which will allow us to pursue a demolition permit. And we hope to be doing demolition in the next 8 weeks or so on that site. There's a lot of work to be done. We're really excited about the opportunity to put another 20 years or so of life into this facility and in service to the community. What you can see in the color-coded portion here are the different clinical pods, approximately 1 to 2 additional full-time providers in 6 different specialties that would occupy this space with a centralized coordination area for all of those teams to work. The top left-hand corner of this diagram is the diagnostic suite with a variety of different capabilities in support of the different specialties. There's also an on-site CLIA lab, a pharmacy, eligibility services, as well as telemedicine capabilities and dedicated rooms for that purpose. So again, very, very exciting effort. Lisa's going to speak a little bit more to the financial components, but we're continuing to refine budget estimates and costs as we're moving forward in this process. Next slide, please. This is the really exciting part, which is the patient impact. This is what it's really all about for us. As I mentioned, there are 6 specialties anticipated: pulmonology, cardiology, gastroenterology, podiatry, neurology, and nephrology. Each of those has a wait time today of between 2 and 6 months, depending on which specialty we're talking about. And in many cases, these are patients that cannot and should not have to wait. There is a significant expansion of the volume of patients and encounters associated with this site. You can see the estimates by specialty that add up to around 25,000 to 40,000 additional clinical encounters that we'd be adding to the system once this is fully ramped up and realized. There is a range there because we're continuing to work with our clinical subject matter experts on what this model looks like. And that's another unique aspect of this, is in a central health environment, we really have the opportunity to design care differently. Alan and Mike both spoke to culturally affirming care that allows us to really address the different social factors that impact our patients, whether that's our scheduling protocols, having early hours, evening hours, having weekend accessibility, having virtual care options, e-consult capabilities, and a real investment on the front end with referral management and triage. This clinic environment will allow us to do things differently, dedicating capacity for our patients, as well as adding the convenience for both our patients and providers of on-site diagnostics, as well as connections to surgery center environments for our procedural specialties. So very, very excited to keep this moving. There's a lot of work to be done and a lot that has to come together, but we're confident that we'll be able to get it done. Next slide, please. Finally, a few additional highlights. A lot of our focus this year is on this continuing development of our direct practice areas. That does not mean by any means that we are done with partnering, done with contracting. That will always be a large part of what we do. And FY23 is no different. Included in the budget that Lisa's going to go over in more detail, there's approximately $3 million for additional primary care, including the sites that will become operational in Eastern Travis County over the course of this fiscal year. Additional investment in contracted specialty care. So again, even though we are working on specialty care in a direct practice environment, that in no way precludes us from partnering. We've done that this year and we'll continue doing that going into FY23 as well. $5.6 million in the operational side. Capital dollars were on the prior slide, but these are the actual individuals and services that will be provided going forward at Rosewood. I mentioned behavioral health and substance use treatment. We need to incorporate additional dollars for the Suboxone treatment that I mentioned earlier, as well as the methadone that we're introducing late this fiscal year, and then additional dollars for post-acute care as well, incorporated into this budget. And happy to help answer questions or provide additional context as we get further in the presentation. I'll turn it over to Lisa.
Thank you, Lisa Owens, Deputy CFO. So I'm going to walk through some of the numbers now. I wanted to just address that on the 27th, we did present a high-level overview of the budget, and those numbers have not changed with the exception of the forecast, the estimated property tax revenue, as we have calculated the exact tax rate and had additional details on the revenue. Oh, yes. So this is the presentation that we gave in the forecast in May. We updated it with additional information based on that certified tax roll. So this is the same information from the 27th. And it looks at, as we talked about, preparing the budget this year and looking at a long-term forecast at 6% over the maintenance and operations no new revenue rate. So we are achieving that goal of having targeted days of cash on hand by FY30 of at least 150 days of cash on hand. Our proposed tax rate, we did bring this to you at our last meeting. However, again, the tax rate has changed just slightly as the calculation was finalized and submitted this past week. It does indicate 12% growth in the average taxable homestead. When we come back next time, we'll bring more information. I know we like to see the bands by the different tax levels. However, this is just the average homestead in Travis County, and that shows a $3.99 tax savings year over year. As although the taxable value has gone up, the tax rate is going down significantly as we calculate that, and even with that 6% over the no new revenue rate. We also continue to have the highest allowable 20% homestead exemption, and you all approved increasing our 65 and older and disability to 110,000 this year. So going back to the sources and uses, again, we fine-tuned the property tax dollars, but not a significant change there at all. Still estimating about a almost $22 million increase in property tax revenue. We continue to have lease revenue and other such as tobacco litigation settlement dollars. Total sources are estimated this year to be $300,750,000. We talked at our last meeting as well, and we provided some additional information in some slides about changing the structure of this sources and uses. So we're no longer showing the contingency reserve carry forward as a source and a use. We're just showing the roll forward at the bottom there in the reserves. So our uses this year, we have our healthcare delivery program. We have two programs, healthcare delivery and administration. We did roll tax collection into administration, so that's shown on one line. But you'll see year over year about an $85 million increase in our healthcare delivery program and an increase in our administration and tax collection for total uses, which I'll go into more detail, of just under 300 million of 299,499,000. Again, our healthcare delivery contingency reserve is shown there, what we approved in the budget last year, where we think we'll end up this year, and anticipated reserves at the end of next year. Going back to that slide that talks about the long-term needs, that provides the reserves that are needed to fund many of the endeavors that we're launching in this fiscal year. In our healthcare delivery program, as John went through, we have, this was our last year in FY22 of the DSRIP IGT. However, we do have a $26 million increase in what we are now calling purchased healthcare services. So all of our contracts with our major primary care providers who also provide dental and behavioral health, a significant increase in specialty care contracted services. The contracted services that we have, we will continue to grow. An increase in specialty care for behavioral health and post-acute care. Again, John went into great detail on these. And then also the Community Health Care Initiatives Fund. So that is a $26 million increase year over year at about $125 million proposed in the FY23 budget. We also talked at length about the provision of care starting at Rosewood Zaragoza. This $5.6 million, I have additional details in a later slide, but it mostly represents the hiring of the physicians as well as the support staff to run that clinic in those 6 specialty areas. However, this also anticipates just a partial year. So when we look at these dollars for next year, they will be significantly higher. But as we anticipate that clinic opening towards the end of the fiscal year, most of those physicians and support staff would be brought on later in the year. So looking at our healthcare operations and support, we also have a very significant increase in this year, and I'd like to talk through some of the highlights. So this section of the budget includes not only our chat program, which we talked about last meeting, is we anticipate maintaining that program and enrollment, as well as increased premium costs. We continue to budget for real estate and campus redevelopment on the downtown campus for some known but other potential projects that may arise. And then in the middle of this section and all the way down to almost the last few lines is from salaries and benefits down to other operating expenses is really where you're going to see the operations of the organization. I have additional details on this on a future slide, so I'll hold off on that. And then we, a major part of this growth year over year is an increase in our transfer to the capital reserves of it was about 12 million last year, and this year we're proposing 49 million. We've gone through that at a couple meetings, and I'll hit some highlights of that towards the end of the meeting, but that does include additional funds for the Rosewood Zaragoza project that we just talked about. Our estimates do come in at about just over $9 million to complete that project, and so the reserves will be allocated in FY23 to pay for that with cash. So our total healthcare delivery is at $277,819,768. Sorry. Our administration program also has some increases. Again, we have a lot more details, so I'm going to hold off on the details. We did talk about some of the business cases in that area, but this also includes one highlight that I'd like to point out. Central Health and the enterprise has moved to self-insured for employee health insurance program. So we would like to hold some cash in reserve this year, about $2 million, to ensure that as the claims fluctuate and the premiums are collected, that we have some funds set aside for the insurance, self-insurance program. So that's that $2 million at the end. That's an increase of just under $6 million. So we're at $21,679,767 in the administration program. We had 2 of our 3 community meetings this past week, and we were able to really provide a little bit more information in this chart, which I really like, that shows those growth areas in healthcare delivery. I've talked through all this, but I think it's really exciting to see the growth in the healthcare delivery program, and especially the beginnings of this direct healthcare services, the $5.7 million for the direct services. This is the details that we have provided. I think we started providing this last year by functional area in healthcare delivery and administration to show you where some of those investments are being made. So to kind of walk you through this, we're just showing you the year over year functional area. It might be 1 or 2 departments depending on the area. The increase in their year over year budget, as well as the number of FTEs that we anticipate at the end of the year. The reason that's important is, as I said, for a lot of these business cases, we may not be hiring until Q3 or Q4. So we did not budget for the whole year's salary, but we are showing you a whole FTE. So the FTEs are really shown towards the end of the year. So just keep that in mind, especially as you look at direct healthcare services, 62 new staff to provide those services. That budget will increase next year as we will budget for a full year of salaries. So you can see here, we do have about 117 new staff in our healthcare delivery area. Much of that was highlighted through my colleagues at the presentations on the business cases, and we've kind of broken it out for you by department. Same with administration. We have an increase of about 5.5 new FTEs, but we also have additional dollars to fund contracted services or other initiatives that may be needed in order to build up the infrastructure in these areas in order to support the growing organization, not only in HR, in finance, but also communications and compliance, as we talked about those business cases. Lastly, before I hand it off to Jeff, I'll just show you this slide again. Again, if I just take you down to the 3rd row, the Rosewood Zaragoza Specialty Clinic, this fiscal year, you did approve about $1 million for professional services. As I mentioned, we anticipate that being about a $9 million project. So we are requesting additional $7.8 million in funds. Our total additional capital funds required for FY23 are approximately $49 million. And again, that accounts for a lot of the increase in the healthcare service operations and support. With that, I'm going to turn it over to Jeff to talk a little bit about the performance review.
Thank you, Lisa. Good evening, committee members. I know this has been a long presentation. I'll try to be as brief as I can on the last couple of slides. I do want to take a few minutes to talk about the Germain Solutions Performance Review, which was a mandated performance review through the Travis County Commissioners Court related to a financial order. That has been a guiding tool that we've used to help influence over the since it was actually performed to help us influence our budget strategy over the years. And I think you see a lot of some of the things that we'll talk about that occurred in the performance review that have occurred both in some of the highlights that John and Alan discussed, but also some of the budget, proposed budget items in fiscal year 23. Just a little history. The Germain Solutions Performance Review was mandated through performance financial order through the Travis County Commissioners Court in 2017, and Germain was selected and approved by Travis County. In addition to the performance review that they performed for Central Health, they had actually performed at least one performance review for Travis County previous to our engagement. The engagement started, I believe, in June of 2017 and was presented to the Board of Managers in January of 2018. Some of the focus areas of the performance review have listed there. There were 6 areas. The financial order also dictated that the performance review was to be performed every 5 years. And that's the performance review that we were talking about beginning the engagement this fall to begin the selection process. Next slide. So just to revisit the actual performance review, some of the major findings and recommendations related to the performance review. Overall, Central Health performance was above average. So there was a benchmarking of both Texas hospital districts and national healthcare and hospital districts. A lot of hospital districts that you hear as leading innovation in some of their areas. As it relates to our rating, our highest rating on the performance review related to our DESRA anchor entity activities. And our lowest rating was specialty care, physician specialty care, which really wasn't a surprise. And even though Germain Solutions looked at a lot of leading healthcare systems, even across the country, they noted that everyone had the same issue we had, that specialty care, even in 2017 and 2018, there were severe shortages. And as we hear constantly, that has not been solved. It's also, related to that, the physician shortages, both primary care was another finding. The partnership model was another finding. And again, this is, we're a unique entity, even looking out across the nation in the sense that we were a payer at that point, did not provide direct services. And the partnership model has some trade-offs. So there's, one thing they noted was the flexibility in our model to be flexible with any changing care delivery needs, but it also limits control and visibility of how those funds are used. Another area was governance was just a lack of board term limits, and then also just tracking initiatives that we had, both benchmarking and then having the data to track our progress related to those initiatives. And then lastly, but certainly not just all inclusive, was diversifying the central health funding sources. And if you remember back in this period, we were coming off the leasing of Brackenridge Hospital, and they did note that we would become much more property tax reliant than we had been in the past. And they suggested that we look at diversification of additional funding sources. So my apologies for this being a little hard to read. But as it relates to progress, major areas of progress that we've made to date related to the performance review. There's been a lot of progress related around the direct practice of medicine, around some of the specific findings of physician shortages of both specialty, in particularly specialty care. None of this moves quickly. And you'll note a couple of the accomplishments. Just the legislative approval was something that took years to accomplish. There's been a lot of work, as Alan mentioned, around the establishment of the Medical Executive Board. And then our initial specialty care service line has begun service around podiatry services recently. So I think that's a great accomplishment related to starting to provide those internal services. Additional service planning and expansion, the development and adoption of our equity-focused service delivery strategic plan. That was recently completed. And then we recently, also the board recently approved the consultant on the next phase of the engagement around both operational implementation and financial sustainability to support all the work that has gone into the first phase. Also, in addition to that, the expansion side of it is just and we've talked a lot about it, I won't go into a list, but the purchase and construction of new clinical facilities. There's been numerous facilities. We wish they could be built quicker, but we are working diligently around the construction of new facilities and renovation of Rosewood, Zaragoza, and in addition, working on making some progress around Colony Park. Improved partner oversight and governance. During this time period, there were some third-party agreed upon procedures related to the $35 million payment to the medical school around how they spend their amounts related to permitted investments. There have been ongoing discussions with Ascension on a direct services model for some time. And then certainly as it relates to tracking some of the progress around some of the data, there have been substantial improvements in our data analytical capabilities, in particular our internal capacity to build out that process. And there's also been, lastly, diversification of our funding sources, both related around intergovernmental transfers and the implementation of the, what we call the LPPF, the Local Provider Participation Fund. And then there's also been growth of additional revenue sources other than property taxes around both lease revenue and recently some grant revenue that we've received recently. So that concludes our presentation. I just wanted to quickly highlight the performance review that had been completed. We have a busy budget calendar. We've had a lot of meetings thus far. First page gets us through our historical meetings. You see we're at August 10, which is our Budget Finance Committee meeting. We have had one change to the schedule, and it's highlighted. You see On September 8th, we are scheduled to go to the Travis County Commissioners Court in a work session to present our proposed budget. So that's a little bit different than our previous schedule, which was August 30th. So I just wanted to point that out. And then of course, we're still scheduled to go on the 20th for our budget and tax rate approval from the county. So that concludes our presentation. Turn it back over to the chair of Budget and Finance Committee. And thank you all very much for your patience on this presentation. It's a lot of great information. We have a lot of healthcare that's being delivered to the community.
We'll start with questions. Do the managers online have questions that they'd like to ask managers? And Dr. Managers Jones, would like to go first?
Okay, first of all, thanks so very much. That was a very detailed, I think, comprehensive overview of the budget. It took a little time, and I would hope that board members have the opportunity to ask some questions tonight as well as other times regarding this budget. As one who's has just completed his 5th year on the budget, a lot has come into knowledge, at least on my part, about what we do, how we do it. And so I'd like to ask some questions from that, somewhat from that perspective. The first one is, and I'd like to go to something you just mentioned a few moments ago with regards to oversight and governance in terms of the Germain recommendation. Indicated in terms of funding, it talked about our funding, the $35 million for the Dale Medical School. I think the word was there needs to be more oversight, or there's what we currently have is limited oversight. Can you speak at all in terms of that issue? Were there any specific recommendations on how to address that limitation, or what more we need to do to do that? That's one of the questions I would have.
Yes, Manager Jones, this is Mike, and I'll start out by answering and then hand it back to Jeff. I think from overall, the Germain Solutions Report said under the partnership model, there's always going to be challenges with having the insight and the control in terms of how healthcare is going to be delivered. And that's unique to a partnership model. So that's I think good characterization, and correct me if I'm wrong, Jeff, on just the overall finding of the Germain Solutions Report, but more specifically to the medical school. I recall that there were some provisions in there. They just escaped memory, but I wanted to address that overall because it's not only the medical school, but it is other partnerships as well. Jeff.
Right. Yeah. Let me add a little bit to that. So yes, Mike is absolutely correct. And there, to answer your question specifically, Manager Jones, there were not any specific recommendations on how to accomplish that.
Okay. Well, as Manager Valadez said earlier, I am very concerned. I've shared with her, and I had asked, and I am asking, that we have some time between now and the budget year, budget approval, to go into closed session as a board and talk about that, and talk about some strategies to address those limitations that may be there that we see, even though Germain may not have spelled them out. It is concerning, particularly what I have read here recently. I understand that you can't believe everything you read, but there are some very alarming concerns that have been raised. And as a person responsible for some of the fiduciary responsibilities for this role, I want to make sure that before I approve a budget that includes this or any other money, that I'm aware of any of the challenges that we have and some strategies. So I would encourage, Chair, that we have opportunities at a future meeting between now and the budget time to go into closed session and discuss that issue. So that's the first thing I wanted to raise. The second thing is, I'd just like to say something, and I'll leave it at this. I am definitely supportive of an increased funding for this hospital district. I have been one ever since I've been on this board that believes that we have been a finance district and not a hospital district. from my perspective. We have finance services, we haven't provided them for the most part. I'm extremely happy and pleased to see that we're getting into the service delivery model. But I think we're a little late in the sense that a lot of the strategies, a lot of the monies that have been proposed tonight and talked about in terms of building facilities, hiring staff, and addressing some of the issues we've identified, had we done this 10 years ago as a true hospital district, the overall cost perhaps over time would have been great or the same, but certainly not as an incremental cost that we're going to be facing over the next several years. So we need to look at and discuss with the public what kind of district we have, what kind of district we want, and how we got to where we are. Because these tax rates are going to be and probably should be increased significantly as we build this hospital district over time. And as a board member, I think those are the kinds of things that we as board of managers should strategically talk about, engage the public with, and go forth in terms of moving that message to the public and to our elected officials. So I'd just like to say that briefly as we get into the budget process. So one, I'd like to ask that we have an opportunity to have a closed session to discuss those limitations outlined by Germain or address those from our perspective, whether they identify them or not. And secondly, as I said at our last meeting, I think we need to have a strategy to talk about how do we get this public to understand that we are a hospital district and not a financing district, and that as we're beginning to build these capacities, we need to engage them in that process. So those are basically the comments I'd like to make.
Thank you.
And if we could do something different, I know typically what we do is we pause and we try to answer each board member's questions, but to the extent that there's similar questions, then we'll circle back around. But I'm taking notes of each question. We'll circle back around to each one.
Okay, so we won't expect you to respond. We'll go around to everybody. Looks like we lost Manager Matvani. I don't see him. Do you have any questions? Do you have any questions? Not this time. No.
Well, thank you all for the presentation. It was very thorough and long and very detailed. Really appreciate it. I just have a couple of questions. The first one's really quick. You mentioned you started the outpatient dialysis clinic, and you started with 10 patients. And what is the capacity for the long term that you're expecting for next fiscal year?
Yeah, you're right. Can you hear me okay?
Yes.
So we wanted to start this out very incrementally. There are a lot of different pieces from vascular access to the physician services, the facility. We started with 5 patients 2 weeks ago. Last week we added 5 more. I believe there are an additional 5 for a total of 15 that have been referred into the program. So we're kind of incrementally adding and ramping that up. But at this point in time, last information I had was we had identified 15 patients for the program. I believe our contract capacity is around 50 patients at any point in time is what we're anticipating based on the clinical data around our patient population.
I think, sorry if I could just add one thing, and it's the potential rolling off of this environment. So at the end of the calendar year, these patients should have access to other programs, which then increases capacity into that program.
It's transitional by design so that we're helping enroll people in Medicare, Medicaid, into Sendero through the CHAP program, the American Kidney Fund for Blue Cross coverage. We're really trying to get people into care so that we can help fill that gap while we actively help them enroll in those other programs.
Perfect, wonderful. Now, I'm quite disappointed. One service line that I've asked for on multiple occasions throughout the years, actually, this is not new, oncology services. And that is a service that is really much needed and fragmented, especially for our underserved population, knowing that they're at higher risk for cancers and they're significantly impacted. And we don't have a way to address their care, and I don't know how and where they do access care in Travis County. for our community. So that is a service that I've asked on multiple occasions, multiple times. I've even wanted to have a special committee to address cancer care for this population, but it never went through. And I want to know what's your plans, and as we move forward for a critical need that we need immediate, that really needs immediate attention. Cancer can't wait.
I'm happy to take it. Sorry, I'm colorblind. I can't tell what color the light is flashing.
I've been trying to use hand signals.
Green and red look the same. So completely agree. And just because we didn't talk about it today doesn't mean it's not an active area of work. So we have current year initiatives that I didn't speak to today in the oncology space, particularly with pursuing additional access for diagnostic mammograms and biopsies and any other kind of breast diagnostics that are necessary to help supplement.
It's not just breast. That's
right. Understood. That's one initiative. There are other initiatives that are underway, and I'm happy to talk with you offline if it's useful around some of our work in oncology. I don't think that is a place that we are planning for direct practice in the short term. That is a incredibly difficult area to recruit the different subspecialties that are needed, and that's likely to be an area that we try to contract and partner around more so than build organically. But just over the course of this year, we also added capacity for PET scans for some of our patients that need that for their cancer treatment. It is certainly an active area. And I should have said earlier, if you remember the COG slide of the different aspects of our delivery system, we have active work in every single one of those spaces. And we really just tried to touch on a few of the highlights this evening, but there's certainly a lot of work going on outside of that.
And I can add maybe a couple other aspects. So in partnership with UT for the CPRIT grants, it's colorectal screening, lung cancer screening, and there's one more that I'm not thinking of. There are 3 different initiatives. We just actually signed a letter of support to advance the lung cancer screening grant that not only offers high-dose CTs, but also case manages individuals through care. As we start building out the different phases of care, diagnostics is advancing diagnostics is one thing that we do plan. Infusions is another one. And then oncology would actually be a different phase due to the complexity. So we have to partner with institutions that can attract kind of some of that subspecialty care as we start to wrap this care. So we do talk about it, and we are working on screening and in-care initiatives, but it's not an institution of oncology.
Well, the concern that I have is like within our budget, I understand there are future plans, but we don't have a fixed amount that we're not actually working toward oncology services. In addition to that, the item line for the DelMed as well for the oncology service is not even really covering our patient population. So that's really the concerns that I have in terms of this area that I hope that we can work. I understand we don't have the perfect solution and it's very complex, but we need a path to get patients where they need and the care, immediate care they need.
That's great feedback. And I would
thank you.
Just add that oncology is included in our specialty care budget. So there are absolutely dollars there, including expanded dollars around oncology.
Thank you.
Manager Motwani, do you have questions? Can you hear me? No questions. Manager Valdez. He said no, right?
Correct. Yes, he said no.
Okay. Manager Valdez, yes. Questions?
I'm not going to repeat what Manager Jones reiterated or stated, because that has been a concern of mine, as you saw when I sent you my comments from 2013 with respect to the $35 million, long before the agreements were ever signed by the board. So anyway, so we can hopefully have a discussion about that, Dr. Bell, in the future. I also, on the Germain report, I'll start kind of from the back, regarding their recommendations and the achievements or what we have implemented. If you can give us at some point in time, a general timeline when these recommendations were achieved? They gave us the report was done 5 years ago. Recommendations were submitted. How long was it before they were implemented? And where are we regarding those? And then let's see, go back to the diversified central health funding sources. From when they also asked that we diversify the funding sources, if we could have who are receiving dollars from now. I know that DSRIP is over. This is the last year, but who else are receiving money from, any substantial dollars other than our taxpayer base and lease agreements with UT? If we can look at the I guess is it the on the budget, I guess healthcare delivery services, we spent $20 million less from actuals for 2022 than was originally budgeted, and 192 to 172, knowing the needs that we have in our population, the increased needs that our population has been screaming for. What can we do to make sure that we kind of overcome what we haven't spent and get to a point where we are spending near to what the needs are for our community? So I don't know if that calls for another community medical needs assessment, so that we can see what the need is, how much are we spending, and how much more do we need to spend in order to at least equalize the dollars that are available for accessing healthcare. With respect to the clinics, I've recently noticed that they are actually now male clinics that are open and providing services outside of our system. We haven't contracted with them. And I know that one of the biggest concerns that I have, and then I know Shannon has with the Black males and me with the Latino males, because they don't get into our clinics. And we are not hitting the demographic numbers for our population. So where are we with respect to how are we going to fill the need that our Latino and Black males, well, me specifically Latino males, but also Black, any population other than the English speaking population for males? When will we be able, what are we doing to educate them, inform, expanded hours, additional services? What, weekend hours? Because I can tell you that everybody that I know in the construction business, nobody gets home before 6 o'clock right now. And that's because they're leaving the house at 5 o'clock in the morning or 6 o'clock in the morning to be on the job. And they're not getting home. They're working 12 and 14-hour days. They're not able to get to the clinics. They're not able to get anywhere. They don't have services because they're getting paid by the day. And that's the majority of the people in the construction industry, which is a significant number of Latino males. And so that is a big, huge gap that we have not yet implemented a strategy, a successful strategy to bring them into our clinics. What can we do to achieve that and close that gap? Yes, that. With respect to the cash on hand and contingency, I'm assuming contingency reserves. You know, Lisa, you said that it's good for us to have 150 days of cash on hand, and yet we have significantly more than that on hand. If there are other things that we have targeted any of those dollars for, could you tell us what they are so that we'll know that that's not just a pot of money that's available for us to be able to implementing these strategies to close those disparity gaps that exist and have existed forever since the formation of this organization. And so how can we touch those monies in order to achieve those goals that we would like to have in closing the disparity gaps that exist in Travis County. And let's see what else. The waitlist comparisons. I know I have been the queen of waitlist requests. I remember when you had to wait a year and a half for specialty appointments in many of our areas. And so it'd be good. I think it would be a good idea for us to have access to that information. Where are we now? We had a baseline established maybe about 2 years ago. Where are we now? And who have we contracted with in order to close those gaps? Are there our partners that we may not be getting services from? I don't want to name them, but we all know that who we're talking about. And I'd like to also know if there are other providers that we are contracting with to be able to achieve those numbers that we're not getting served by existing contracts. I think that's the way to put it. And where are we there? Where are we now? How can we, when do you think that we would be able to close that down to where if you have a need, you're going to get in? You know, that to me is the success. And we can provide services to those people, especially in specialty care, when they actually need it. And under primary care utilization, you have FQHC provision, but I'd like to know if we have access to disaggregated data. Is it Lone Star Circle of Care? Is it community care? You know, who are the People's Clinic? Who is providing the services to our population? I think that's a good thing for us to know, a good piece of information to have. So if there are any concerns or recommendations that we need to implement or strategies that we need to implement in order to close those gaps, what can we do? For right now, that's it. I'll submit some more information or questions to you, Lisa and Jeff. Thank you.
No questions, Dr. Chair.
Oh, one last one, I'm sorry. IDS.
Oh, are you ready? So was there a question about the budget for this idea?
No. Included in our budget has been the allocation of funds for our IDS system. And I was just curious as to whether or not we've already achieved our goals with specific. I know John Clark was at one point in time talking about our needs and access. If I'm not mistaken, it was John, or who was it? Jonathan? Was it you? They talked about our IDS? No, somebody. Everybody has talked about it, including UT and Ascension Seton. But Central Health is the one that's supposed to be funding that. So I was just curious as to whether we've already achieved whatever we said we were going to accomplish, and that was full implementation and revamping of our IDS system. And that was so that we could have access to better data and better communication between the services that we're providing are being provided to our patients by providers and us, our patients' ability to be able to communicate so that their needs are being taken care of. That was my last question. Thank you.
Sir.
Oh, I'm sorry. Manager Jones, did you have some more to say? Do you have another question? You might have to unmute yourself.
The reason my hand was raised is because I thought that Mr. Giesland indicated that we were going to allow people to make their questions and comments and then they'll come back, but it sounds like we're entertaining. So if we're going to start entertaining, then I'd like my questions answered appropriately as well.
I'm sorry, he was about to go. Did you have more questions, or did you want him to respond to additional questions?
He didn't respond. He was going to respond to my first comment.
He's responding right now.
That's the beginning.
Yeah. He's responding right now.
Yes, sir.
If you don't, you know what, after he talks, I'll check back with you to make sure your questions were answered. Does that sound okay?
Yes, okay.
Chair, that was my fault. I jumped in and answered questions out of sequence there. My apologies, Manager John.
So I will start off answering these questions as best we can. Some of them might actually necessitate attorney-client privilege discussions, and so I'll note as much. And then when I pause, then I'll ask any staff that is either online or in the room that can further elaborate to please do so. That'll work, Madam Chair. Thank you. So first, on the Dell Medical School, you had asked for closed sessions, but in the future, but actually those discussions have already begun to happen in open session. And it started with the discussions that were originally planned for June, but they got moved to July, as you'll recall. And so there was a robust discussion. And there is yet additional discussion with this board to deliberate what the relationship and what the next steps are with the Dell Medical School in light of the affiliation agreement, but also our health equity plan that identified some gaps, but also the imperative to look at all of our partnerships, including the medical school, to determine, how is it that we go forward and address these gaps together. And so there is, and that includes the 35 million. So again, those conversations have already happened. They've already started. They're not done yet. There's still some more deliberations that need to come back to the board. If things pertain to the lawsuit, then obviously we will need to go into closed session so that you all can have the benefit of consulting with both internal and outside counsel as necessary.
Well, Mr. Giesler, before you go on to the next one, if I may just ask, my intention is not to hide from the public discussions. The reason I say a closed session is because there are a lot of questions that I'd like to have answered with regards to the agreement that I don't know would be appropriate to have in open session. So that's why I suggested, but if you're comfortable that we proceed with having them in open session, I would encourage that we put it on agenda item, have it before the budget hearing is held.
Well, what I would recommend then, I better understand your question. So thank you, sir, for the clarification. I think that if there is something specific to the agreement, then let's have a quick huddle with counsel to figure out what we can talk about in an open session versus what warrants attorney-client privilege in light of the lawsuit. But I understand your question better. Thank you. But it might be a mix, both closed and open session. So
well, I think in light of what has been put in the public venue today and over the last couple of days, as a board member, I'm asked, and I'm also in an unusual position to try to respond to something that I can't answer because I don't know all of the details. And I don't think that's a fair or appropriate to any board member. So in order for me to get a complete, thorough detail of yes or no, this is or is not, it would be helpful for me to have that detailed briefing. Now, if we can do it in public, that's fine. If we need a closed session, I think it would be helpful. Yes, we've had open sessions discussing those, but we have not had the level of details that I'm being heard about what previous boards have done. And as a new board member, I need to be aware of that, I think, so that I can speak articulate to the public about what has and has not been the case.
Yes, sir. And I guess I'll need to have myself and legal counsel visit with you, because I know a couple of meetings back, and I'm thinking is whenever we were meeting at the Austin Independent School District headquarters, we brought in legal counsel as well as we had in-house counsel that provided overviews and answered questions around the agreement and the lawsuit. And so I guess I need to circle back with you to see what about those particular briefings maybe were lacking in your opinion. Because
well, I won't get into the question right now. I'll do it offline.
More conversations, but I need to do some quality checking and bring legal counsel to meet with you to figure out, what in those particular briefings you felt maybe was lacking.
Okay, that's fine. I'm just saying is that I think one of the things is in the public venue now, whether or not we have the opportunity to do some of the things with Dell or cannot do a DEL? And I think those are the kinds of questions I'd like to get a history on. How do we get there, or if that's true or not? So I'll be happy to meet offline, but I don't think this is necessarily something that's confined to closed session, because one of the major issues is out there in one of the local newspapers. So
certainly we can bring back prior briefings as necessary. So second was discuss with the public about what we would become as a healthcare hospital district. And again, this is already happening to some degree, but there's actually other inflection points, other key large-scale opportunities to have those discussions. More recently, and thank you very much for coming to the Colony Park meeting, is we have been having community conversations, not only in the voices of the community as a follow-up to our health equity plan, but more recently with our budget discussions that we've been having. We are talking about our imperatives, all aligned towards establishing a higher functioning healthcare system, but in particular talking about the direct provision of care. And that has sparked some interest in the community conversations that we've had. And so we're going to continue to have those conversations, but that's just the start of it. There's an entire communications cascade, obviously, that gets built around these things, and you all were briefed in the last board meeting about the different ways that we go about putting together those communication plans. But in addition to having communications built around what we're doing relative to our strategic direction and our budgets, is we also have the performance review coming up that Jeff had outlined for us. And granted, the board, now granted, we're also working obviously with the county, they're having to decide and complete their deliberations, but setting aside the county for a moment, coming back to this board and saying, here's the scope of the performance review. We need to go back and see what our progress was, what are the opportunities going forward. Part of that performance review from 2017, 2018 had a very open public component to it. It wasn't just a desk exercises where there were meetings set up where we had conversations led by third parties, not ourselves, about the healthcare district and what the future and what the direction would be for the healthcare district. And that's, it's my personal opinion. I don't want to speak for the board. Obviously, you all have the final say, but that is a critical component of any 5-year performance review or 3-year performance review or 7, is knowing what does that strategic direction look like? What are you going to grow up to be? Because the public as taxpayers and people that benefit from our services need to know. Lastly, in terms of a public opportunity, if you will, we have operational plans that are going to be developed to ensure that we fulfill what the board had adopted in February with the healthcare equity plan. So obviously there's yet another opportunity to have the discussions that you've outlined. I don't want to foreclose on this and say I've just outlined 3 opportunities and that's it. Obviously, as we see things, or you all see things that are opportunities that we need to take advantage of to have those larger system and existential discussions, and we can certainly do that. But those are 3 that come to mind that are on the books right now.
Well, if I may reply to you, Mr. Giesland, embedded in that, your comments, and hopefully I'm misunderstanding, is the implication that I have not either engaged in, understood, or participated or heard anything that has been in the previous meetings, and that is not the case. What I'm asking for or trying to get at is, particularly as it relates to this understanding of the healthcare district, you've outlined what we're going to do, and I think that's good. I'm supportive of those, and I think we need to that. We're moving that way. I think that's important. The presentation today talks about how we're beginning to be more of a service district than a financing district. I want to be clear. My question goes for the public to understand, how did we get to where we are? We didn't just wake up one day and say we're going to be a financing district. The voters voted in 2004 that they're going to create this district. I think it's important in those dialogue and those discussions that we share with them at some point. A board or a group of individuals made the decision that we're going to go this way versus the other way. That's important. And why is it important? It's for the last 14 years or so, we've been operating under this model. And this model was was not voted on by the public. It was voted on by a board or some group that made the decision. Embedded in that is that we have spent money of the taxpayers to operate in this way that we could have had invested earlier, been further along the line than where we're trying to go now, which I'm supportive of, but which we could have done maybe 10 years ago. So I want to make sure that we don't lose in this discussion, how did we get to where we are now? That's, I think, is very important.
Yes, sir. No, we agree. And Manager Jones, I want to apologize to you. I wasn't trying to implicate you in any way, shape, or form. And if I said something that was implicating, I apologize. But also, in going back to what you're saying about making certain that we not just quietly acknowledge, but openly and publicly acknowledge what the pathway was that got us to this point is essential, whether you're talking about a 5-year performance review or operational plans or just having community conversations about why we are what we are. So I certainly agree there. And that's something that, especially with the performance review, I think is probably the biggest and loudest opportunity, for lack of a better term, to talk about that history that you so aptly outlined. I would say with Dr. Zamora, there's a lot of working knowledge there about some of the history and the decisions that were made. And so I think there's probably a discussion that we need to have, perhaps in the Strategic Planning Committee meeting, as we start to pull these plans together, that I think we can memorialize a lot, even just within these board confines, to start that process of publicly having those conversations. And I'm not trying to put words in your mouth, sir. I'm acknowledging what you're saying, and kind of thinking out loud about how do we operationalize what you're saying. But
there are documents and memos, I'm sure that we have that can outline how we got to where we are. So I'm talking about a thorough evaluation and not just Dr. Zamora giving his history of it. I think that's important, but I'm thinking about we need to look at the documents that have gotten us to where we are.
Yes, sir. We will see to it that Dr. Zamora does not have to write any reports. Absolutely. We all agree. We agree.
What you need to understand, Shannon, 10 years ago, the managers then are just like the managers now. We loved our patients. We wanted to take care of our patients best we could. Yes, things could have been done differently, but at that moment, that's what we thought was best for the public. We didn't have the infrastructure to bring in, what Alan and John have brought us today, the infrastructure for a specialty clinic. We just didn't have it. But the managers in 10 years ago had no malice in their hearts. Every one of them was a kind, generous, nurturing person who loved our patients.
I'm not questioning that, Dr. Zamora. I agree with you. We've had board. My argument is not to fault what has happened. Mine is to talk about how we got to where we are. Having said that, though, there were hospital districts that existed at that time that had models that we could have had been examined, looked at, and perhaps moved a lot further along to where we're trying to go had we started earlier. I'm not faulting anyone. I'm just thinking for the public records, the public needs to be aware of that.
Then we need to look at the windshield, not the rearview mirror. Stop looking through that windshield, rearview mirror, and look through that windshield. Let's do what John and Alan have talked about. Let's move on. Let's do what's the best thing for the patients.
He or she who fails to remember their past are doomed to repeat it. And so I want to make sure as we go forth that we don't repeat some of the mistakes of problems without acknowledging what we did so that we don't get there again. That's the gist of my argument for that history.
Members, there's a way to get to where Manager Jones is pointing. There's a pathway there. There is.
Go ahead. I'm sure there is a pathway, and I understand that we both need to know our history and we need to know our future, and I know that that you can provide that. My question though is, can you ensure that when you provide that history that you go back to the actions of the Austin City Council before this district was created?
That will involve a look back at the city, and we can even, we have a resident historian that's happy to go back to the days of the prairie. People showed up and kind of stuck a wagon. So yes, there's actually quite a bit we can do.
Yes, I think that for everyone to really understand the history, you'd have to go back to actions taken by the Austin City Council before it was created. It is. It really is. It's fascinating. Thank you.
On the dialysis, on the dialysis question, I think John's exuberance got out there and answered that question, and that is, and folks, if we could, in case there's any folks or even patients listening, just a quick round of applause on the dialysis. That is a major event. That is a game changer. That is a quality of life. That is, it brings so many benefits, and so it's a great thing. On the oncology, I know that John had answered that there are some contracts currently in place where people are receiving services and not just screenings, but I think the only thing that I would like to put out there is, while we can put together contracts and partnerships to help our patients with this community lacking, although there are a lot of voices at the table right now, it's just taking more time, is this large, best-in-class, world-class system. But it needs to work for those who are socially vulnerable, people that we serve. And I think it's really a community-wide conversation. And yes, we're at the table and we're going to step up and do what we need to do in addition to what we are currently doing. Because I think the current pathway to just think, well, we just need to keep contracting, that's not a long-term strategy. We're not trying to sell that at all, as our patients deserve better. But I think that cancer conversation in oncology across the spectrum, there's some other staff folks that I think we would need to bring probably to strategic planning, most likely, to have that conversation.
Well, I appreciate that, and I've actually been in a few of the meetings, and I understand the complexity of it, but I'm hoping to be the catalyst to move things along however we can, because it's an urgent matter. That's really where my calling is. I understand we don't have the magic wand. There's a lot of players into it, but we need to find a solution, and I don't know how that solution will look like, but at least a pathway for our patients to receive the necessary care when they need it. So that's about what
Well, I think, if I could link back to what Manager Jones was saying about understanding the history where we come from, and then what you're saying about oncology, I think with the budget resolution, not only does that direct staff, but it also can be an expression of the board, and it takes a majority vote. So for instance, you could have something in the budget resolution that it is imperative that we continue to be a driver and contributor in community conversations around building out an oncology and cancer treatment, screening, treatment, and prevention programs here for Travis County. And just to show that, we're going to dedicate time, as we currently are. So you're memorializing something that's already happened, and I'll let others wordsmith that. But same thing for going back and looking at the history. I mean, there's no reason why you can drop that in the budget resolution to say one element of the performance review shall be. And so I think you've got some latitude here to set some priorities. And then on the timeline, getting to Manager Valdez's question, in terms of the implementation, we can go back and take a look at that. We've done something like this before. It may be a little dusty, and so we need to update it. We'd like to, if I could, ask that we bring that back to the Strategic Planning Committee meeting, most likely, but we'll need some time, but also understand that we're focused on the budget. We're focused on getting clinical services stood up. We got business cases and trying to build out programs that you heard about tonight. So bear with us as we put together that timeline. We will need to do that, I think, as an exercise in getting ready for the next performance review, because whatever firm does the performance review is going to want to know that anyway. but I do want to make sure that we don't do the consultants' work for them if we're paying them. So it'll be a high-level type timeline. On the diversification of the real estate of the funds for Central Health, I will say that that's, and we need to have a conversation with the board that I've noted about Brackenridge towards the end of this year, as we've stated before in the executive committee meeting, because that is part of the diversification of the revenue, is to have real estate revenue coming from Brackenridge, and that's going to be a significant piece of our non-tax revenue. The other element about diversification of revenue sources was philanthropy, and this is something that the Germain Solutions had pointed to. We actually had some community conversations and stakeholder sessions around building out a philanthropy program, and there were a lot of concerns with that. And originally, we thought, well, why not? But then when we started working through our stakeholder groups and community conversations, the concern was Central Health is going to come in and take our money. And we are working to raise those funds, and we're going to be competing for the same dollars or the same grants. You may say, well, we'll try our best not to compete for the same grants, but that's hard to do. So at the time, it was decided, okay, we'll just shelve that for now. We can certainly come back to it. But lastly, although it's not a revenue source, I think a key component is that if you're limited as a governmental entity and how you can diversify your revenue, then you need to look at where it is that you can have substantial savings. And I'd like to point to the administrative office consolidation in the Hancock Center. That is one purchase that, done right, it will result in significant lease savings over time. And so if you can't diversify the revenue, then look for your big cost savings further down the line. Now that requires a lot of business diligence, and you've got to have a lot of foresight into thinking, okay, what's the timeline on this, and somebody that can put together all the modeling. But that's another response, I think, to diversification of revenue, where you can't always just go out and increase sales or introduce new product lines like a corporation can or the government. So, but it's an important part of our fiscal picture. Moving on to the healthcare. Yes, please.
With respect to that one point.
Yeah, right.
Thank you, Dr. Sawan. With respect to also seeking efficiencies, we're an enterprise, and case management, we have case management that we've built out in Central Health component, but we also have it in Syndicate. We also have it in community care. Those are all entities that we take responsibility for. If there were ways to efficiently, put those various responsibilities in one unit that's doing it for all the enterprise members, that might be a way to reach an efficiency that we could all benefit from. Thank you.
Well, it's a cross training too.
That's exactly right. Yeah. We recommended that for the school districts, with their federal programs, et cetera,
right.
And it worked.
So each case management function, and I use that term very generally, it does, there are a lot of commonalities, but there are some very unique differences. For example, what you would do in a regulated insurance environment versus a healthcare district. But I'll ask others if there's a more responsive answer.
That's great. I think the insurance environment is somewhat different. I think there are obviously opportunities there to better align. I can tell you that with the build out and the gain of sophistication and us maturing, even creating more specific swim lanes. And so give an analogy, as a family med doc, you can train in a training environment where you're the only resident. And that means you're the anesthesiologist, you're the surgeon, you're the generalist, you work in ambulatory, or you can go to an academic setting where you can't even see the patient because there's so many folks standing in front of you. I think the environment in which we were in before was our case management folks doing everything, because they were everything. Now, as we gain information, knowledge, and expertise, we've got utilization, we've got medical management, we've got transitions of care. And so what that does is it allows us to partner with the appropriate partner organizations in order to be very specific in our job, in our skill sets and our responsibilities to hand off patients, more specifically, take much better care of our patients, and also set our folks up to succeed, because now they're not responsible for anything. They're responsible for A, B, and C, and they're handing off to somebody who's responsible for A, B, and C. So it does create alignment, and that is exactly where we're working. Great question.
On the healthcare delivery, you'd mentioned the difference between the 192 and the 172, and I'll ask Lisa and John to respond to that. But as with any budget, it starts out as an estimate based on service levels and both known and perhaps not fully known factors. But then as you get through the year, you see, okay, well, this didn't turn out the way that we thought it would. Or perhaps maybe it was for launching a service line, but that service line was launched much later in the fiscal year. And so you just didn't incur costs front loaded, at the first part of the fiscal year. IGT and the timing of the IGT has a significant role in terms of what ultimately is expended in any given fiscal year. And so those are just a couple of examples, but I'll turn it over to Lisa to walk through some of those differences in more detail, or John, either, however you want to handle it.
I'm happy to do that, but I could also do it during the financial statement presentation.
Even better, yeah. Because that actually lays it out. You can see budgeted to where we are year to date. Probably should have just said, Lisa, take it away on that one. I'll know better next time. Also, you talked about the need for men of color health, and this is something that I think as a community, it's not just Central Health, it's everybody leaning into this. And currently right now, our partner, Community Care, they've established I believe it's a twice weekly routine at the African American Men of Color Clinic up there on 290. And he started the services in July. And so I've committed to Jason verbally that we would circle back around, let's say 90 to 120 days after they've had some experience with patients to see, okay, how's it going there? What is it that we can do under our existing service level contracts? And I've had these conversations with John Morgan as well. I would say it's in terms of outreach and making sure people understand, whether it's the individual themselves or perhaps the person that they trust. It could be a spouse, a partner, family member, a brother, sister, friend, religious figure. It could be any number of people, but when visiting with folks about enrolling in engaging in healthcare through the medical access program, that is something that I feel like that we've made a lot of strides in. And I know you all had presentations on outreach and MAP engagement, MAP enrollment, but on the care side, and then on some of the social services side, so those things that are wraparound, because there's only so much care that can be delivered within the four walls of a clinic or a procedural room, but it's really working on those community partnerships. Now, there's a lot of work that we still need to do in that regard. You'll hear more about that as we talk about achieving achieving health equity through a high functioning healthcare system, because it's not just about the clinical piece. That is about so much more that goes along with that. I will say that on the access to clinical services, that has improved significantly. I'll ask Alan to speak to this, but our partners at Community Care having walk-up capability or capacity, expanded hours, not always requiring an appointment, because Manager Valdez, to your point, if you take off work for a shift, that's the difference between groceries and not. And so meeting people where they are in the situation that they're in is absolutely critical. But Alan, I don't know if you have additional comments on the accessibility of clinical services.
Not many, Mike. I think you covered it, other than just the methodology. So telephonic, video. I think some of the lessons that we learned during COVID are still being utilized.
And lastly, on this topic, as you saw in the imperatives, having member engagement and enrollment, again, I know I've already talked about that, but I did want to point out that that is one of the imperatives under our healthcare equity plan, and some of the resources that we're building up this fiscal year and the next fiscal year are designed to meet that imperative. There is a lot that we need to come back and talk about because we all know we always come back and talk about enrollment, utilization. And those dashboards are on the website. Anybody can see them, but when we come back and brief the board again, we will obviously report on how we're doing with that engagement. Talked about reserves, what timing that Jeff should have to exit the room, but he had, I know, talked about what the reserves were going to look like at the start of this budget engagement. Lisa's covered some information today, but as you saw in the packet that this evening, there is a pretty significant investment or spend down of reserves. Obviously, and this came up in a community conversation here just yesterday. Somebody had asked about the reserves, and those are there. And I want to commend not only this board, but prior boards in making sure that those reserves are what they are, because it gives us some stability in terms of what we're building out, what you heard, what's happening this fiscal year and what's going to happen this next fiscal year. It ensures that we can continue to do that year in, year out. It has a softening or a cushioning effect against any sudden tax rate changes. Because you have those reserves, you can control spikes in the tax rate, or control for spikes in the tax rate. Also, as you're thinking about the capital projects that you saw, you need to be able to reserve for, whenever you have debt. So, Jeff, I don't know if there's any other comments that need to be made on the reserves, but suffice to say, if I could point back to the slide that Lisa covered, where it showed that very steep downward slope, there is a plan to get those reserves down. And that's not theoretical. That's based on known expenditures and investments. Yeah, I like that.
Fair characterization of looking out. That's why we look out this a long period, so that we know where we're at currently. And then what's ahead. Oh, sorry. And then what's ahead.
On the wait list, I know we brought wait list reports in, but I'm drawing a blank on the time frame that we do that. I'd have to think about the board calendar, Brianna, about when we do that, but let's see when that is. And if there's some more conversations, because we've got our analytics just keep getting better and better, and so we can certainly come back and flesh out more detail on the wait list. I just don't remember what month we typically bring that back. We're all kind of looking at each other, trying to remember the board calendar in memory, but if you'll bear with us, we'll bring that back to the exec committee and get it set.
I know there's some dashboards. This is Perla, a dashboard item
so it's
next month, or for August 24th.
But I think the wait lists are further on in the fiscal year once we get the data and put it through the release process. Okay, so that's something that we still owe you on this. But again, we'll build on what we've shown you before, but just with improved analytics. That's right.
Yeah, well, we previously we would do the wait list. We finally established a baseline. We've been providing these lines of service. This is the population that is supposed to be on scheduled for a specialty care appointment. This is how much time they have had to wait. And we also got told in the past whether they just dropped off or whether they provided service. That was information that we were given, but I have not seen that kind of information in a long time. That's all I'm asking, is that would be important for us to have.
Yes, I think we bring that at least once or twice a year but let's go back and look at the calendars and work with the analytics team, because, and again, this is something that I'll ask for forbearance on, because we are trying to get this budget across the finish line, and we have some partnership agreements and discussions coming up that we've turned our attentions to, that it'll be further later in the fiscal year.
Well, that was one of the reasons that it was important for me to get that data.
Yes.
Because why would I want to renew a contract with a provider who's not providing those services, or have they dropped off? I don't know that. I'm just hypothesizing.
Understood.
Thank you.
Point well taken. And then lastly, on the clinic breakdowns, you had asked about, who is serving whom, and I know in the financial reports that'll be covered this evening, we do show by dollar amount. I'll have to go back and look at the utilization reports if we break it down by primary care provider, but I'll have to go back and look at those reports. I just can't recall off the top of my head what the utilization dashboard shows.
Mike, if I could just add, so there will be specific budget allocations for those providers. And I believe before the board takes action, we also provide a list of all of our contractors, so that information will be coming. But to your point, Mike, and maybe to Pearla's a minute ago, I think we have some dashboards that are coming to the board in the near future that speak to services by primary care provider. Certainly Lone Star Circle of Care, People's Community Clinic, in addition to community care. We also received some primary care services from the UT School of Nursing, as well as Volunteer Health Clinic. That makes up the majority of the primary care service.
Thank you. So I hope that answers a lot of the questions. I know there's some that we've put a note next to that we do need to come back and report to the board as part of our normal reporting cycle, but we will get to those issues.
Manager Jones.
Yes, I'm sorry I had my hand up earlier. I just have sort of a technical question. The first one, is it possible to pull back up that slide that had the Germain solutions recommendation? Is that available relatively? Or if not, if you could just read that first one that related to the Dell Medical School, if you could read that one off.
You want us to read the one about the Dell Medical School?
Slide on the Germain recommendations.
Okay.
They got it.
Under the recommendations, it says, trying to see the one on the Dell Medical School, overall performance, highest rating, most governance. Is that here? I don't see it.
I think it's on the next. I think it's on the one, improved partner oversight governance. It's the two more down, I think, two more slides. Is that the one you're asking about?
Yeah, it mentions particularly about limited control or monitoring of, okay, yeah, third-party agreement upon procedure related. It says improved partner oversight and governance. So this is a performance recommendation to us to improve partner oversight and governance regarding our third-party agreement related to the $35 million payment to Dell Medical School. So that is a recommendation. So I guess my question is, and this is to, I guess, our lawyers, as part of our budget process, if we have not been able to ascertain whether or not we've been able to get improved partner oversight and governance, is it possible, and I don't know if this is a question you can answer now, that we could say, okay, as part of the budget process, we will defer funding that until we have in place something that can speak to that?
I believe these were just recommendations. I don't believe that it's tied to the budget. Is that, do you guys have an answer for?
No, it's what I'm saying is these recommendations are to us as a board to be able to do these things. And so my suggestion or idea is it possible as part of our budget process that we're going through now is to say that in order for us to improve partner oversight and governance as it relates to this specific one, our third-party agreement procedures related to the $35 million, we'd like to have in place certain things that before we allocate those monies, or that we defer those allocations until after we have those things in place. That's just a question I'm asking. One, is it legal? And two, is it something from a budget point of view that we could do?
We have a response from
Shannon, Manager Jones. I think both prongs of what you're talking about is correct. Number one, we have to look legally what we can do via the agreement that we have with UT. We also have the necessary authority with regard to our budget as to what can be paid out and what can't be paid out. So you have to balance those two to address the situation that you're talking about. And as Mike said earlier, there is a process to get there. It's not going to happen tomorrow, all right? But it is a process to get there. And we can discuss that further when we're talking about this either meeting or agenda item that we're going to have at a future meeting to talk about UT payments.
Thank you, Dr. Bell. That's exactly what I was asking for. Now, having said that, I just want to make sure that we either put on the agenda item for a future meeting prior to the budget, a process to do that, because it's been my experience both in other governmental agencies. We will say we're going to do that, but we will not come up with some specific measurable evaluative processes to do that. And so I just want to put on the record that I'm requesting that we do that before we approve the budget.
It's part of the resolution process.
Go ahead, Mike.
No, that's the extent. As part of the resolution process, that's where that happens.
Correct.
Yes, and that's why you know the board of managers, by virtue of a motion, can make a motion, and if a majority agrees, then it goes into the resolution. I would, again, as with anything, for legal counsel stares a hole in me, as with anything that you put in a resolution, doesn't matter what the topic is, you need to make sure that you run this through legal counsel. But that's within the resolution. Yeah,
and that would be my recommendation, Mr. Giesling, is that obviously we vetted through that process.
Your recommendation is noted. Thank you.
And next time I'll make sure I'm there and not here at home, because I didn't have the opportunity to make my points as clearly there as I am here. So thank you.
I think we are hearing you very loud and clearly. We really are. Do you have additional questions? Because we said we would come back to you to make sure you were heard. Do you have more questions you'd like to ask at this point, or how do you feel? Oh, I think you might be muted.
No, those are the questions I want to ask, and I appreciate you taking the time to answer them.
There's no motion necessary for this. So we're gonna move on to the third agenda item, which is to receive the fiscal year-to-date healthcare service expenditures made by and accept the preliminary May and June 2022 financial statement for Central Health and Community Care Collaborative. Lisa Owens will be presenting.
Okay, good evening. So I'm going to go through the June financial statements. And what I'll do is try to hit some highlights. The question that was raised about the year-end estimate being $20 million less than budgeted in healthcare delivery and about $2.5 million less than budgeted in administration. I'm just gonna, I don't have all the details here, but I can hit some highlights of the areas in healthcare delivery where we feel we will be under budget this year. And that, I think, makes up some of that. And certainly I can follow up in more detail if you need it. So we are at the end of the third quarter. These financials are through June. This is when our tax revenue slows down significantly, as that will has primarily been collected earlier in the year and due in January. Our balance sheet has total current assets of $455 million, primarily made up of short-term investments and cash. And we have restricted cash and investments of $222 million. Significant portion of that increased year over year, you'll see, is our CO for construction, as well as cash reserves that we've restricted for our projects. We also had $18.5 million restricted for the LPPF at the end of June. In our capital assets, we had approximately $85 million net of accumulated depreciation and capital assets. So as of June 30th, 2022, total assets of $763 million. We had current liabilities of just $16 million. No significant changes year over year, with the exception of the debt service payable, as we had not issued the COs at this time last year. So you see additional debt service payable in that line item. We also were holding those funds for the LPPF, again, $18.5 million. And you'll see the debt service now payable for those COs that were issued. So our total liabilities were $111 million. Net assets, restricted and unrestricted, as well as capital, totaling $652 million. And again, liabilities, net assets equal to $763 million. So our sources of funds, again, a small amount of tax revenue we did get. We also had our lease revenue and other revenue. The highlight of this month was that we did receive another grant from the Episcopal Health Foundation. I believe you all voted to accept that last month, and those funds were received in the other revenue line. So we had about $2 million in sources of funds as of in June. I'll go into more detail on our healthcare delivery, but just to highlight in the administrative program, our budget this year was $13.2 million. We were estimating between administrative and tax collection, so that's a total of about $15.3 million, to be about $2.5 million under budget. You'll see that is primarily going to be in consulting, as well as other purchase goods and services, and then salaries. I can tell you that we've had vacancies, we've had hard to fill positions. So in our salary areas, we are seeing higher vacancy cost or a lack of spending in salaries. We also had some positions, and I'll talk about this in healthcare delivery as well, that, as I mentioned in the budget for FY23, we learned, oh, those were end of year hires. So we are budgeting a little bit better. So we may have budgeted, I'll use my program, the hub program, may have budgeted that for the whole year, but we knew we weren't going to have the report, and I'm happy to say post that job, which it's posted, until later in the year. So we will have some savings there. So looking at healthcare services, I'll focus on this slide and the next, just because, again, about $20 million we're estimating that we're not going to spend that was budgeted. So as you know, we've talked about specialty care, and many times there are new initiatives or there are new contracts that may take time to execute. We do anticipate higher percentage of spending in primary care, but we will come in under budget on that $17 million line item for specialty care. Now, some of that is also due to the fact that we do budget for unknowns. So we have lines that you've seen in the specialty care and the primary care before called primary and specialty reserves. And in years past, we haven't done it in a couple of years, if we had a contracted provider that was going to go over and we needed some capacity, we may have accessed those. I think we were doing a great job of planning. We're growing the number of providers in specialty care, so we've not had to access those dollars, but they are in the budget. We also, you'll see, had about we're going to be about a couple million under budget in post-acute care. And then, as I mentioned, this all other healthcare services, what's in that line item is about at least $4 million that I can think of off the top of my head of those primary and specialty care reserves. And so at this point, we don't anticipate specifics, but if we had a need, we would come to you towards the end of the fiscal year. So we do anticipate, really quick, probably about $6 to $8 million under budget in that area. looking at a little bit more detail on the ACA program, we anticipate being on budget, so we won't have any budget shortfall there. Campus and healthcare campus and facilities. So we talked about downtown campus. I will say you'll see that we budgeted $1.5 million for consulting and $4 million for other goods and services. That includes professional services. That campus, we do budget for things that may come up. We are looking to develop that property. We want to have those funds available if an opportunity presents itself. So those funds will most likely not be spent, certainly not the full budget this year, although if a project does come up, we would need to access those this year. Then in the healthcare delivery operating costs, this is another area that you'll see we're 3/4 of the way through the year. We're not 3/4 of the way through the year in that last line of other services and purchased goods. We did have some funds in there, and again, I can get more details, but I would anticipate being about $6 or $8 million under budget there in this section as well. Again, positions that were not posted till later in the year, physicians that we waited to hire until we kind of got the team together, and then other dollars for contracted services that we may have thought may be needed, or projects that could have been delayed. And so we will see a shortfall in that budget. So between the contracted services, the downtown campus, and those healthcare delivery operating costs, it makes up about that $20 million. We'll be under budget. Those funds, though, all carry forward in that contingency reserve. So we still have the funds, they're in cash, and they're available to fund those projects that we've talked about that we will need over the next 8 years going into 2030 to maintain the reserves that we need in the long term. Really quickly, we do have the budget here. I know it's not the utilization and it doesn't tie to patient dollar care, but it does show you the dollars in the contracts to our primary care providers, the top 3 there. And we are at about 61% of that budget. Again, we anticipate, you'll remember that several years ago, we moved to a lot more performance incentives in those contracts. So we do spend in the fourth quarter and in the last month of the year as those incentives or performance payments are made towards the end of the year. And John, we talked a lot about specialty care. This is the current specialty care budget. You'll see the dollars of the year-to-date expenditures there. We have highlighted some of the expansion. I think John hit on that in that FY22 slide. A lot of that through community care and also through new providers who are providing additional service expansion in those areas. And then our $700,000 budget for oncology and other areas there. So our total specialty care is $11.9 million for direct service lines that we have planned. But again, you'll see down here this MAP basic expansion, which was the possibility of expanding MAP basic, and then systems planning expansion. Those were all covered in last year's budget. At this point, we spent none of that, and that totals just right there about $5 million. So hopefully that covers some of the variances in our year-end estimate, but certainly if you have additional questions, let me know. Yes.
Oh,
yeah, let's go over. You want to start up on Manager Jones? Do you have any questions?
No, I have no questions.
Great. Manager Watwani, do you have any questions?
Thank you. No, Chair.
No questions. Manager Brett, do you have questions?
Just a quick one. I was also wondering if any of those funds that weren't expended were due to COVID and the fact that there were certain types of care that could not be provided for months given the COVID environment, should we say.
So I'm going to ask my colleagues to talk about what we started to see in the trends in the primary care setting and the specialty care setting as a result of
COVID. Yeah.
So great question, Manager Greenberg. So I think this year we really had the challenge of trying to predict what would happen from a pandemic perspective and whether we would be coming out of a pandemic or still in it or having one that intensifies. There was, and if you recall some of the earlier slides, there was a major shift in services over the course of the pandemic. A lot of folks delayed care. There was a lot more acute care associated with the pandemic itself. We saw a pretty significant drop in use of urgent care over that time period. And so when setting the budget for FY22, we really had to take our best educated guesses on what utilization would look like and set budgets that would accommodate our best guess and probably a bit more in case those volumes exceeded what was expected. To a large extent this year, our service volumes in primary care have started to recover. They have not yet recovered to the pre-pandemic levels. So we expect to continue seeing some of those service volumes increase over time. That first bar chart I shared earlier on patient visits had a lot of additional patient visits, but many of those were specifically related to the pandemic for vaccine visits, for testing, for acute treatment. Sorry, that's probably more detailed than.
Thank you, that was helpful.
Thank you, Lisa, as always. You do a phenomenal job. I know you highlighted intentionally the oncology services, but I also want to emphasize that only 33% of that budget was used. Still, there is room for improvement. I just wanted to highlight that. Thank you.
I'm making more of a statement with respect to the reason for my questioning about expenditures and specific strategies and programs that are reaching into the Latino, hard to reach, marginalized population. 50% of the deaths were Latino, of the deaths during the pandemic. And when you're talking about a population that is a significant amount of our MAP population, our less than 200% FPL population, I could promise you that the majority of those deaths came from that area or that arena. I can promise you that. So there was a significant deficiency in how we treated Latinos in Travis County. And one of the things that I want Central Health to do is be the best that we can be for all our populations, whether we speak English or not, whether we are black, white, brown, purple, yellow, polka dot, I don't care. But all our patients have to be served, and they're not being served. And that is, I think, partly due to staffing at that level. That's maybe a holdover from a different mentality on the administrations that existed within the funding entities that we provide money to. And, I've asked time and time again about integral care, how they're targeting our Latino population, because I've dealt with MHMR for the entire length of time that my daughter has been in existence, and with the special ed population in various districts and counties throughout Central Texas. And I can tell you that very few compliments came to case managers or direct service providers to that population, non-English speaking, English language learner population that was within their ranks, within their patient population, which is also our patient population. And there's nothing we can do to control what other entities do. The only thing we can try and do is do as I have done since before I ever got on this board, and that is to push for a demographic representation top down that reflects the population that they serve. There's no other way, there's no better way to say it or to put it. It has got to be that. 31 years ago, I entered a system that was providing a holistic approach to the provision of care, and that's at Scott and White. I wondered why Central Health was not implementing some of those same strategies. And I think that we have the opportunity to do that. I'm very, I may be somewhat constructively critical of us sometimes,
But I want you to know that this administration gives me hope that we can accomplish those things and that we can accomplish them during our tenure on the board. And I want to thank you all for working hard to make sure that we get the actual numbers and the data that we need to have in order to act. But I also want you to know that we have a long way to go. And I want us to be cognizant of the fact that until we reach that demographically appropriate staffing and culturally appropriate and linguistically appropriate staffing from the top down, not the bottom up, because at the bottom, you know, we tend to reach that. That's why you have a high turnover, because they don't necessarily get paid for the jobs that they do, and their case totals overwhelm people, especially if they're just coming out of the School of Social Work at UT. But I'd like for us to look at diversifying our staffing, looking at the performance of the providers as they provide services for us, and looking at their success rates and how they provide those services and to whom within our purview. That's the only thing I ask. And I'll talk to y'all about the budget stuff when we meet. So thank you. Anyway, I just want to thank you all very much for what you do.
Thank you. No questions, Dr. Chair. Just a sincere thank you to everybody.
Yeah, thank you so much for putting that all together. I know it was a lot of work. No, all of your jobs are a lot of work. There's no motion necessary for this item. Right? Are we done? Ugh, we're not done. You have more to say? Just kidding. Fine. Do I have to recognize you?
No, you don't have to. That's true. The power of the chair.
You don't. How tired are you? I was like, wow, it seems like we have some left, but that's something else. Okay. Just kidding. Take your time. You spent time on these slides. Talk as slow as you would like.
Well, the CCC, I will just go through the balance sheet and the sources and uses. As of June 30th, did have cash and cash equivalents of 11.2 million. That primarily is the total assets of the CCC. We did have $11.3 million in liabilities and net assets of negative 50,000. So just liabilities and net assets equal to 11.3 million. I will say that the DSRIP funding did come in July. So the July balance sheet looks much better. So the timing in that time of the year when those funds are coming in. So as of June 30th, however, we did recognize some DSRIP revenue that was that was reserved for potential review through the audit of the DSRIP program. Those funds were released because we had no findings. So we had a little bit of other sources, which is primarily interest income. And then in the healthcare delivery program, $9.3 million, and DSRIP project costs at just about $5.4 million. On the details of the healthcare delivery that does make up that $9.3 million, we did have year over year a very consistent picture if you look at the prior year to date column. But we did have about $1.5 million in specialty care, our specialty behavioral health, which a lot pays for the inpatient care through integral care, and post-acute care, and then some operations. So that makes up the $9.3 million in uses of funds.
I think you've asked this, I think you've answered this before. DSRIP funding, do we know, is there a end date for that?
This is the last.
This is it, right? I wanted to make sure.
So you would have seen in the central health budget, this is the last year we budgeted to transfer the IGT. So we anticipate this would be the last year for the funds to be a source for the CCC.
So I just couldn't remember, and I was hoping it was not this. I thought we had some more time. Thank you for that. Does anyone have questions for this part? Yes, please take your time.
No, I'm tired as well. A quick, if this is a long response, you can follow up later. but how in the future will we be able to balance the CCC budget once we lose IGT district funding? So that's really my question. If it's a long answer.
It is a semi-long answer.
Manager Jones, do you have any questions?
No, I do not.
Okay. Manager Montwani, any questions online?
Thank you, Chair.
Anybody in the room? Please take your time, ask your question.
With respect to the CCC, are we looking at dissolving the CCC at any point in time? And with respect to DSRIP, I just want clarification that as we presented our projects to the feds for approval on the DSRIP, that the reason for that project was to gain knowledge, information, strategies that would be implemented into how we conducted our business. So there would be a gain financially, but there would also be a gain with respect to the knowledge and the experience garnered as a result of those expenditures, and change in the process or protocols or practices in order to incorporate that learned outcome. Is that correct? With respect to the second part.
Did you ask me the second part of your question?
That was the second part. I just wanted to make sure. The first part was where we
understood the first part. Yeah.
The second part is I just wanted clarification as to whether or not the DSRIP projects, as we request approval for funding and get that money back to conduct that project, that information that we gain as a result of the expenditure of those funds on the accomplishing the goals of that project, that information is supposed to be reincorporated or incorporated, not incorporated into our protocols, our practices, and our strategies, so that we no longer had to repeat that, because we would have gained that information and incorporated into how we conduct business for that particular project.
Yes, understood.
Is that correct?
Thank you. So, as with respect to the first part of your question, that ties back to Manager Musaida's question, which is right. It's a fairly long and lengthy discussion, and we need to have, as district winds down, need to have that in a different setting. With respect to the funding, it harken back to prior district reports that we provided to the board. That's been part of it, is taking the learnings from those projects, and some of those being operationalized and folded into our ongoing operations. But I'll let others that are more familiar with the operations and the details to fill in the blanks there.
Manager Valadez, just want to make sure I don't get too far off the topic, but as you probably recall, the first DSRIP program was really around projects and capacity building and additional access. There's additional primary care and additional dental services, additional specialty care services, additional infrastructure from a technology standpoint. The vast majority of those initiatives and the expanded services were continued even after the expiration of that initial program. Mm-hmm. The second round of the DSRIP projects was really focused on clinical outcomes. And I think there were about 30 different clinical outcomes. And that's what this current performance has been based on. And last calendar year's performance is what we're now receiving payment from HHSC for. Even though that program is ending, a lot of those practices are now baked into day-to-day work at community care, at Lone Star Circle of Care, our DSRIP participants, Hospice Austin, and those are embedded parts of what they do now. I hope that answers your question.
Yes, the answer would have been yes, Cynthia. Thank you. I appreciate that, Jonathan.
Yes, ma'am.
Anyone else? Right, now we go on. Now is, there's no motion as to that item. The final items to confirm the next Budget and Finance Committee meeting date, time, and location. Managers, we do not currently have a scheduled Central Health Budget and Finance Committee meeting. If a need for a meeting arises, we'll work with the committee members and other managers to choose a date and time that works for everyone's schedule. At this time, accept the motion from Drew.
Thank you to all the staff present and out there who did all the work that we cannot see. I move adjournment.
All those in favor? All those opposed? All those abstaining? That's it.
Thank you, members.
Thank you.